Good morning. I am thrilled to be here today on this somewhat sunny, soon to rain Wednesday morning, June 23rd in the suburbs of Chicago. And this will be our last major program, we hope, that will be conducted virtually. We're gonna dip our toe in the water in the fall, probably mid-fall to early winter, before we start getting together. But we are very, very excited about all of the programs we have coming up. We'll share some of those with you. Let's move on to our next slide. Well, this is me. I'm Cheryl Larson. And here is a little bit about the Midwest Business Group on Health. You'll notice our new branding. I'll talk about that in just a second, but we are catalysts for change in healthcare and benefits with our employer members and all of our members, really. We're one of the oldest and largest nonprofit employer coalitions in the country, representing between 4 and 5 million lives. Our members spend our employer members, well over $12 billion annually on healthcare. We are a community of your peers, a sharing and friendly environment. So we hope you can come to some of our programs for the remainder of the year, whether it's virtual or in person or in 2022. And we're a trusted source, and that makes a big difference. And our members talk to each other and benchmark and share with each other a lot. Next slide, please. Here are some of our upcoming programs and the way you can register. In July, we've got Microbiome, the Future of Diabetes. On the 14th, we're working with the Illinois Department of Public Health and the CDC on an executive briefing on the National Diabetes Prevention Program. So if you've thought about participating in the DPP, please join us. You'll be able to ask questions and learn more. Early August, we've got a program on purchaser expectations for providers, payers, and suppliers. We have got Elizabeth Mitchell, the president and CEO of the Purchaser Business Group on Health, and her policy colleague, Sean, and I can't think of his last name. We also have some great information about navigation services and advocacy. And then finally, you'll see, save the date, May 4th and 5th, 2022, we're back in person at the JW Marriott on Adams in Chicago. Please make sure that you get that on your calendar. Next slide, please. Here's just a few reminders about MBGH. This is what our new website looks like. We're still making some final tweaks. You can see the new branding in the far upper right, which is a big deal. We launched this at our annual conference about 5 weeks ago. You can see it's very easy to navigate all of the employer resources that we make available for members, like our employer benchmarking surveys, all of our program summaries, including a recording and the PowerPoints, our action briefs. I'll talk about a few of those today. Our toolkits, I have a slide on that, and then lots of great stuff for you to use on COVID-19. Next slide, please. Here's an overview of our toolkits. We just relaunched our hemophilia toolkit. The managing specialty drugs, which is kind of in the middle of the page, is a big part of what we're going to talk about today. You can see we have a couple on diabetes and related comorbidities. We've got all different topics. Take advantage of these, and these are available to any employer, any stakeholder, anytime. You don't have to be a member at no cost. Next slide, please. And I just wanted to add this, a quick reminder for our employer members. And if you're thinking about becoming a member, we do peer-to-peer meetings with employer members so that we can learn from each other and share what's going on in the marketplace. This was especially important during COVID-19 last year. And a little bit later, Denise Giambalvo, MBGH's VP, is going to talk about this. Member Connect is our real-time employer benchmarking platform. We conduct frequent benchmarking surveys of employers to find out what they're doing, to learn from each other, dig deeper. And then here's just an example of some of the community-based initiatives that you've either been hearing about or you will be in the near future that we are involved in. Next slide. Here are our partnerships. We are extremely proud of them. These are organizations that you may participate in, whether it's as a member or as part of their events, but we have informal and formal opportunities to share information on their educational programs and their research. So we're very proud to be working with these organizations. Next slide, please. I want to thank today's sponsors. If we didn't have great sponsors that supported these monthly programs for us, it would be really difficult for us to put the programs on, because there's a cost to all of this, not only staff time, but also when we're in person, there's other costs. So you're going to be hearing a little bit from our sponsors today. And Mindy, thank you so much for including information on the sponsors in the chat right now. And if she hasn't already, all of today's PowerPoints that we're allowed to share, and I think it's almost all of them, if not all of them today, will also be included in a link in the chat function. Next slide, please. This is an HRCI accredited program. You will have a copy of this presentation, so you'll see the activity program and the number of credit hours awarded here. Next slide. And of course, we have lots of different ways to stay connected with us, not only Twitter and LinkedIn, and you can use those today. Here you can see the hashtags, but again, a reminder about our Member Connect. Next slide. As you can see, I'm talking pretty fast because I want to get through a lot of great information that you can look at again later. And I'm going to continue to do that so that we can stay on time and on task. This is our recently launched annual employer benchmarking survey. And here I have focused on almost all things pharmacy benefits, and I'm not going to go into a lot of great detail. Next slide. We ask this survey every year in the current year, and then what employers are doing or plan to do in the subsequent year. The top threats to affordability of employer sponsor coverage, not surprising, is specialty drug spend, followed by high cost claims. And right now that's a little bit of a combo of much of what we're going to talk about today. You can look at the rest of that later. No major big surprises, but you definitely can see the collective thoughts of our employers in this slide. Next slide. Payment reform strategies, specialty drug management coming up as #1 in terms of what you are currently addressing. Okay, so the majority of you are addressing specialty drug management, COEs and episodes of care. Those are the top 2, followed by steerage within networks. Those are the items in green. The items in blue are those of you that plan to address that in the upcoming year. The other options are do not address these. Those are red. So you can see at the bottom, vast majority are not even looking at advanced primary care or price transparency with member incentives or bundled payments or reference-based pricing. But what I love about these slides is it's kind of a roadmap of the things that you could be doing and you should consider doing, whether you're doing them or not. It's giving you thoughts and ideas, and then you can collaborate with other members to see what their success level is. Next slide, please. Now we have 3 slides on pharmacy benefit strategies, and it starts with those of you that are currently offering. What are the top things you're offering versus what you're going to offer in 2021? What might you remove in 2021, et cetera? Plan design steerage to lowest cost drugs, very, very popular. 83% of you are already doing it, along with MTM and use of authorized generics. Next slide. I'm not going to go into a lot of information here, but as you're looking at these 3 slides, next slides, you can see what members are doing, what they plan to do, and what they plan to remove in the future. So keep that in mind. Look at the key. Next slide. And next slide, please. If you have any questions about the survey, let us know. Of course, it wouldn't be our annual employer forum on pharmacy benefits and specialty drugs if we didn't talk about our 12-year-old National Employer Initiative on specialty drugs. We have an employer advisory council of large self-insured employers. You'll see many of those at the conclusion of today when we do our employer panel. In 2020 and 2021, we launched many benchmarking and action briefs. This fall, based on kind of the topic of today, we're going to be launching a brief about what the emerging coverage strategies for high cost rare disease and gene therapies are. We're hoping to solve some of those problems with our speakers today. In 2020, we also launched precision medicine and pharmacy design, and that covered pharmacogenomics and genetics. We also launched Transforming Pharmacy Benefits, the Role of Biosimilars. So if you haven't seen those, you definitely want to take a look. In 2018, our first big employer action brief for this project was drawing a line in the sand, and it outlined this top 7 things that PBMs do that are increasing your costs and what you can do about it. When we started this project 12 years ago, we thought we'd be able to have a real impact by working with PBMs and other intermediaries in pharmacy benefits, and that has not happened in the way that we had hoped, but we've got large, progressive midsize and large and jumbo employers who have done some really cool things, and our goal is to always share that with you. Our online employer toolkit. This is one of the first things we did. A lot of our sister coalitions use it, our members use it, strangers use it. We're so grateful, and we just relaunched it. Not only did we update it, and we're continuing to update it, but we completely rebranded all of it. So take a look at that. Today's forum is on here. Our annual meeting is on here. Next slide. One thing I don't mention here is that I think we did over 35 MBGH events, or maybe 31 MBGH events in the last year where we talked about the project in one way or the other. And then I think we did well over 20 outside events where we're referencing the project and our activities in this area. So can you go back one slide, please? Today's theme, actually, go forward, sorry about that. Today's theme is managing the spend for high-cost therapies. And when we talk about high-cost therapies, we're talking about specialty drugs today and in the future, orphan drugs for rare diseases, which can be extremely expensive, and then the emerging gene therapies, and a significant number of the drugs in the pipeline are these really, really high-cost gene therapies. And we're wondering how the heck are we going to pay for these in the future? We know that there's this robust pipeline. We're hearing rumbling from employers on what the future might look like. So we started asking around. We asked employers through some of our employer advisory boards. We were asking some of the vendors and consultants in the community. We even asked drug manufacturers, and we found a lot of different things that were not really innovative. And you know, much of the innovation that happens in the marketplace today is coming from self-insured employers. So we said, how are you going to cover these? The 2 top most common answers are either PBM carrier solutions that charge a PMPM to spread the cost of the therapy out over multiple years, or deferring payments over time. The problem with these options that it's just really shifting costs. It doesn't change the cost or the quality or the efficacy of the drugs, and it also allows intermediaries to continue their model of misaligned incentives. And you know, as part of this project and MBGH talking a lot about waste in healthcare and pharmacy benefits on the medical and pharmacy side, the intermediaries have not wanted to make less money, and it's at the expense of the self-insured and the fully insured employer. The other 2 options that we looked at, and we're still in the process of talking about, are performance-based contracts with intermediaries like PBMs. And we think these have potential. We have one example from one of our employer members for hemophilia. And I won't go into that right now, but they're requiring their PBM to make sure that people that have hemophilia are not overutilizing emergency room visits, that they're not having bleeds, regular bleeds, because they're effectively and appropriately managed. There's much more to it than that. But most employers can't get their vendors to agree to these things because it impacts how much money they're going to make, the rebates, the money on top of the money that we shouldn't be paying for. And then the other option we talked about was outcomes-based contracting. And we think that has potential, but that's going to occur primarily with the drug manufacturer, and they aren't quite sure how to do that. They struggle how to do it with health plans and other groups out there, and no one can quite agree on what the patient outcome should be. So we're going to talk about some of these things during our concluding employer panel. Unfortunately, we're kind of left back at square one, but we're going to continue to pursue it. We're going to continue to talk to employers. And I wanted to share with you on this slide, this is an example of actual employer quotes from these programs that I mentioned that we have conducted. So you see about 1/3 of the folks are saying, you know, we feel we need to cover these drugs. Another one says it would be rare where we wouldn't cover it unless the cost was more than the company made in revenue that year. There are other employers who are saying, you know, maybe these new therapies don't go through the health plan. We do a carve out. We can't continue to risk bringing these costs onto our balance sheets if we know the cost of the drug may outstrip profit. A lot of information in here about needing evidence to prove if we're going to be paying $250,000 or over $1 million. What's the evidence to prove that it's better than the other drugs on the market, et cetera. And I would encourage you to read these. I think they're very telling. The last one at the bottom says, in the end, employers need to identify new ways to pay for high-cost drugs, bottom line. So a lot for us to be thinking about today. Feel free to use the Q&A function to ask questions when we call out for that. At the end of each session, we'll have a question slide, and we encourage you to ask questions. Denise and I will be fielding those, and I am honored to introduce our first speaker who's going to talk about the specialty drug landscape and the role of high-cost drugs. Before we do that, I would like to introduce one of today's sponsors, PSG. They're going to share a little bit about what's going on in the marketplace today.
Data. You have mountains of data, but what is the value of data that is hard to use? Rtbc transforms integrated healthcare data into actionable intelligence at your fingertips. Stop wasting hours pulling reports from multiple sources or waiting for days for a custom analytic. Rtbc enables you to instantly measure the performance of your drug program, manage with clarity and transparency, and move the needle to control spend, trend, and member outcomes. Robust filtering, proprietary rules engines, and an extensive library of interactive reports unlock the answer to all of your drug management questions. Request your demo and discover how Rtbc transforms billions of claims records into actionable drug management insights for over 22 million integrated lives. Data.
Thank you, Rtbc. Could you go back to, there we go. By the way, that was not PSG. That was a little bit of information about one of our sponsors, Rtbc. So hopefully we'll have something from PSG later. Staff will let me know. Again, I'm honored to introduce Dwight Davis, who is the director of the Evidence-Based Prescription Drug Program, or the acronym is Ebrx, at the University of Arkansas for Medical Sciences College of Pharmacy. Ebrx manages prescription drug programs for a number of Arkansas state government plans, including state employees and public school employees. Through the program, Dwight partners with Rx Results, who is also one of MBGH's purchasing partners, to incorporate the Ebrx formulary management strategies into the prescription benefits of employer groups across the states. So we're very excited to have Dwight with us today. He knows where the skeletons are buried. He understands the way that we can innovate in the future, and he's just a great guy. Welcome, Dwight.
Hey, good morning, Cheryl, Denise, thank you, and to all of the participants. And I'm honored to be here today with you, and just excited about our discussion.
Thank you. Do you have your video on?
I do.
Okay.
And
can others see? Oh, there you are, Dwight. I'm sorry. My fault. I'm going to go on mute.
okay, I guess we can start with the first slide, please. Okay, well, good morning again, everyone. My name is Dwight Davis. I'm a pharmacist, and I serve as the director of the Evidence-Based Prescription Drug Program, as Cheryl indicated, and also serve as a director, on outside relationship, which I think is important, and I'll touch on it at the end of my presentation. Director of Clinical Services and Payer Engagement for Gemini Health, and we'll talk very briefly about that. But I've practiced for nearly 40 years, and much of that time has been spent managing pharmacy benefits. 15 years in a senior leadership of a PBM. Most of you may know Alan Gardner, who's on the call, who is with Rx Results. He and I worked together previously in the PBM space, spent 13 years here at UAMS, in the entire time managing pharmacy benefits. Although my topic or the title of the presentation regards specialty drugs, rare diseases, gene therapies, when Denise asked me to consider, having this discussion, she and I worked together back when she was heading up the coalition, Employers Coalition in Arkansas, there in Fort Smith, and she was familiar with our program. It's a unique model, and primarily the objective is to talk about, the approach that we use, because we wrestle with the same thing as you guys do in terms of these expensive drugs. And in your survey that Cheryl was presenting, it resonates with the topics that we'll talk about. So I realize that most of you on this call are participating in managing your employer's benefits. And so we struggle with those same things. We also understand that this current model is unsustainable. And I think that's, the concerns that surfaced in the surveys isn't because you're not excited that a new therapy to treat Alzheimer's disease or cystic fibrosis hits the market. You're worried about the sustainability, and can we continue to provide affordable and effective healthcare for the employers or the employees who have served us and makes each individual company great. And that's what we're all concerned about. So I'm coming to you today, not as an industry expert, but as a colleague that has the same questions and concerns that you all do. And I'm just going to share the intent is to share the things that have worked for us in our model and the things that have not. And hopefully we can, there might be something said that might benefit you all, and I hope to learn from this group as well. But just a quick thing here on this first slide is, who is Ebrx? And we're a service unit within the UAMS College of Pharmacy here in Little Rock. We were established in 2004 to help develop the preferred drug list or formulary for the Arkansas Medicaid program. And we served that program from 2004 to 2016, so a very long time. And in a parallel fashion, we began a relationship with the Employee Benefits Division, which is the agency who oversees benefits for the Arkansas state employees and public school teachers. And so that relationship's been in place for several years and has evolved over time. And just recently, say in the last 3 years, some other state agency groups have, they've recognized the EBD model and wanted to be a part of that consortium or umbrella, so to speak. That's Arkansas State University, Arkansas State Police, the Arkansas Municipal League, and the University of Arkansas System, which is our own health plan. So we think it's important to try all of these concepts out on our own health plan before we introduce those to other things. And one thing that, and Cheryl's already mentioned it, Rx Results back in 2008 was formed. Rx Results was formed at that time, and they licensed the intellectual property that we develop and some of the key aspects that we'll talk about today. And they commercialize those in the private sector. And currently, Rx Results operates in 22 states. And so I know many of you in this conference are familiar with LG Hansel and Alan Gardner. I believe they're on the call, and great business partners, and they can certainly address any needs that you might have if there's something here that would benefit your plan. And so, it's exciting to have our intellectual property go outside of the state of Arkansas. So next slide, please. In order to understand the model and the approach that we use, I think it's important for us to take a step back and look at the pharmacy benefit and all the essential components that make up these, what's necessary to run the pharmacy benefit. And so I'll just say too up front that my comments are not to disparage the PBM industry. I know that there were there was a comment I saw in the survey that the middleman can add cost to the prescription benefit, and that's certainly the case. I'll just say this on the positive side is that PBMs are essential. You know, the claims processing aspect, no one in the world does it like they do it. But I also think that we all recognize that there are slices of this pie that represent additional revenue streams for the PBMs that may or may not be wholesome or effective or financially in your best interest. And so, or even transparent, or that you are even aware of. And so a lot of times, and it's not to say that that's bad or good, it's just, it's different. And so when it comes down to a business partner of yours and their incentives are not aligned with your incentives, that could create, you know, some stress. And so we've seen that. And so we firsthand experienced this at the state of Arkansas. Our relationship with the Employee Benefits Division began as a consulting relationship alongside and it was one of the big three PBMs that managed the plan. And we experienced firsthand some of the lack of transparency and inflexibility and the resulting increased cost and just frustration. And as Cheryl had mentioned, you know, I know where some of the skeletons are hidden. Spending several years helping manage a PBM and then coming to this side of the table, I knew that things could be done a little differently. And so the state really gave us the chance of a lifetime. And they said, okay, well, if this model isn't working, then just blow it up and redefine it and design it the way you think it should work. And so what we did, we were given the opportunity to draft an RFP back in 2015, put that on the market. It's interesting that the big three never bid on it. They just, it was just not a good deal, I guess, for them. And so MedImpact wound up being awarded the business. And essentially what we did is we took, just in a very simplistic form, our RFP requested claims processing and a pharmacy network. Those are the things that they do well. And then we wanted to at least control everything else, or at least have some input on it. So the pieces of the pie shaded in gray were the PBM owned services like, you know, claims processing, pharmacy network, retiree drug subsidy support, whatever the case might be for our Medicare eligibles. And then the green slices of the pie were things that we took control over. So the clinical management, the establishment of the formulary, the benefit design, the rebate contracting that aligned with the formulary. So we knew exactly by moving drug A to drug B, what impact at an NDC tablet capsule level that would have. And that was essential. We also, you know, provide customer service, member service support. And so we, you know, if issues occur with the benefit that we've designed, we should be on the hook for explaining it. And then the reporting and analytics and feedback to the clients. The yellow shaded slices, mail order specialty, that just means that we have you know, we oversee how that's delivered. And we'll talk a little bit about the specialty pharmacy component. Mail order pharmacy, you know, I'll just say, you know, being in this industry for a long time, very rarely does that translate into significant, meaningful savings to the employer. Now, it may be convenient and all that, but we've just not seen it, so we don't promote it. And plus, Arkansas is a rural state with a lot of independent practitioners, and so politically, you know, we don't do it. So that doesn't mean it doesn't make sense for you. That's just kind of how we've handled it. But we wanted to make sure that those benefits were appropriately delivered to our plan. And so next slide, please. This is just a listing, you know, kind of to blow out that pie chart a little bit, is that these are the specific services that we provide. The drug review process. I'll just walk through these one by one, but this is where it all starts. We've talked about, creative payment models, and how you finance particular drugs. And so our approach is that we're going to review and apply the evidence, and we'll talk about that just in a slide or two about how we go about that. But this is the most critical, I'll say, out of all the things we do, this is probably the most cost-effective or effective tool that we use in controlling drug cost, is at the point of entry, because once the horse is out of the barn, you won't get it back in. And so we take a very judicious approach on approving drugs to add to the formulary. We also have a closed formulary, and that means that the default is that no drugs are covered until we add those to coverage. Most plans will have an open formulary, and the default is to cover all the drugs, and then you can exclude them one by one, or you can take them off. But we like to start with a clean slate, and then add. Once we've decided to add, we do it at that point. The drug coverage and prioritization criteria we author for the, of course, we evaluate the drugs. The decisions are, we cover it without restriction, we cover it with criteria, or we exclude it. And so for drugs that are covered with criteria, we author those. And most of the time, those criteria generally will mirror the clinical trials in which the clinical benefit was demonstrated. As far as clinical or the benefit program, we work very closely with the PBM to help program the changes that we've communicated into their adjudication system, so claims will adjudicate properly. We also have a prior authorization call center staffed with pharmacists and physicians that handle the enforcement of those policies. So we develop the policies and then we enforce them, and so we do that through the call center. Have a medical director, associate medical director, who are physicians who handle the appeals and peer-to-peer interactions for requests that we cannot approve. Other program design, I saw one, Cheryl mentioned reference-based pricing. We do a lot of reference-based pricing. Rx Results, of course, they've expanded that program and really been a huge partner there. That is a very effective way to control cost, and we've used it for close to 20 years, and it's worked. We also, as I mentioned before, took over the manufacturer rebates, and we also have access to the medical claims to the plan. And if you could ever do that, you're going to be able to tap into some other drugs we'll talk about in a second. But our rebate program lines up with our formulary. We start with clinical first, establish the formulary, and then we line up our rebate strategy with the structure of our formulary, not the other way around. We don't chase rebates. We use rebates when other options are not available to us. We also will participate or help support our clients in the review of the PBM contract and just relationship management, since there's so many moving parts. Okay, next slide, please. In terms of the specific review of how we go about reviewing these drugs, and all drugs are reviewed that are pertinent to the pharmacy benefit, and so we use the best current peer-reviewed published evidence, and we generally adhere to this pyramid design here. I'll say up front, I do not do this. I mean, that we have Ebrx hires clinical faculty to perform these reviews, and so I couldn't perform a clinical review with a gun to my head. So we have people who are very good at this. It's a subspecialty of pharmacy that that requires doing this all the time. And so essentially what we try to do, or the objective, is to get the highest quality of evidence and the lowest amount of bias. And so that's really, in a nutshell, what we're trying to attempt here. Sometimes with these rare diseases or these gene therapies that have been a topic, you don't really have the benefit of these randomized controlled trials. Sometimes you have to look at a single arm trial or something with a little lower quality of evidence, just because it's an orphan disease and the studies have not been done. So this is not a perfect model, but it's a guideline, so to speak, that we go by to evaluate our drugs. The one primary point I wanted to make here, and this is where a lot of times the rubber meets the road, is that the evidence does not always align with the FDA approval. We'll have requests for specific drugs that are low value frequently, and the argument is, well, it's FDA approved for that indication. The reality is, in some cases, that the evidence points toward the drug is extremely low value or ineffective despite the FDA approving the drug. And so we'll use the FDA approval when, we don't always exclude that, but it's a data point. And so we will adhere to the evidence. And so next slide, please. These are just some examples of low value drugs that I'll just point out based on the process that I just described. But this one, kind of stands out. It says Exondys 51 used for Duchenne muscular dystrophy. In the package insert, this doesn't really require a lot of in-depth review of peer-reviewed published trials, but this one sentence appears in about the first paragraph of the FDA-approved label. But highlighted in yellow, it says continued approval of this indication may be contingent upon verification of a clinical benefit in confirmatory trials. So the way we translated that and what we saw in the clinical trials that we did look at was that the drug didn't really work. And the FDA basically confirms that here. And so this cost $1 million annually. In fact, we adopted or actually added a client that was paying for this because their large health plan and their owned PBM had approved this, and so they were, this represented a revenue stream for them at the expense of the plan, and it was a very small plan and had a detrimental financial impact until we could get this shut off. And a lot of times, what we'll do is if the evidence doesn't exist, we go back to the drug manufacturer and say, our plan doesn't pay for experimental therapy, and if you want the patient to continue on this therapy, you'll provide it. And we're successful a large portion of the time because we don't pay for their clinical trials. A couple of other examples here: HP Acthar gel, used for infantile spasms and in a variety of other inflammatory conditions. Compared to low-cost injectable corticosteroids, the evidence just isn't there. $35,000 per month for that. These knee injections that you'll pay for on the medical side, best evidence we could see is they were compared to saline or saltwater injections. And this third bullet here is huge because this is where you'll see this, is that multiple oncology agents that we will exclude from coverage, primarily because the FDA benchmark is progression-free survival, which means the tumor may shrink, but there's no extension of life or no demonstrated extension of life or high quality or reasonable quality life, or it doesn't talk about the toxicity. So a lot of these oncology agents are very low value, and as a result, we exclude a lot of those out of the chute. Now we'll continue to re-review as evidence changes, and a lot of times we may change or alter our coverage policy, but we stick to the overall survival data where appropriate in making our coverage decisions. And then just kind of outside of the specialty area, but it's significant to your total spend with the anti-diabetic agents. Just give you a couple of examples. In one category, Januvia and Onglyza there, we look at cardiovascular benefits of these drugs. People aren't dying from high blood sugar, they're dying from cardiovascular events and end organ damage. So we're looking at what are the outcomes of using these drugs. Are they moving a lab value? Are they lowering your A1C a little? What does that really do? And so we have demonstrated evidence that these do not impact cardiovascular reduction in cardiovascular events. So we've excluded that category altogether. And so those are examples of how we use the evidence to support the benefit design. Next slide, please. The result of that prior, the PNT review, and I'll kind of pick it up here, is that over the past 12 months, we've recommended for exclusion 73% of the drugs that we reviewed. Not to say that that's anything that's good or bad, but I think it amplifies the low bar that the FDA has on their drug approval process. Next slide. I want to touch on one bullet point. I've already mentioned the first two about the prioritization policies aligning with the clinical trials, and the rebate contracting aligning with the formulary design. This is one thing I'm just going to toss out as a, you're talking about managing the cost of specialty drugs. And I think I recall a conversation that Denise and I had about the group there in the Midwest Business Group on health, that accumulator programs were not well thought of, because I think several of the groups had tried these and it turned out to be a disaster. And they can be if they're not managed properly. But the one thing I wanted to point out, and we can go to the next slide, and I just wanted to make a couple of points. We're using an accumulator program for all of our clients, and we're saving, this one program is accounting for 10% of the total, a savings of 10% of the total RX spend, not just specialty, but the entire plan. It's very effective. And what we're basically doing is we're determining what the copay assistance amount is, spreading that out over about 13 months, and then assigning that number. Let's just say if it's $2,000, that's the copay. And so we program that into the system. And so I'll just say and so we're collecting that money off the top. But we're also not passing, we're allowing the patient to save in that as well. So just 4 requirements here to make this go. And I realize that you may not have this flexibility, but I also wanted to share it since it's so impactful. Number 1, an engaged PBM that will execute the program correctly and be flexible. That was key for us. Number 2, determine the patient assistance amount divided over 13 months or so, make that your copay amount. Number 3, an automated mechanism to capture the real out-of-pocket, such as $5, what the patient actually paid as opposed to the full copay amount. So you don't want your claim showing that they paid $2,000, because they'll just meet their maximum out of pocket. It'll have an unintended consequence. So you have to true that up on the back end, and your PBM has to have that functionality. And so one thing that made this all possible is that we identified a local specialty pharmacy that cooperated with us. They're extremely flexible. They've helped us design this program. And so we've been very successful, but it's required a lot of hand-holding, but it's relatively a small percentage of your total claims, but very effective. So anyway, next slide. Currently, the specialty landscape, and you all know this, but I'm just going to toss out some high-level numbers that in case you don't know, specialty drugs typically account for about 0.5 to 1% of total claims and greater than 50% of your total plan spend. So this is a big deal. This is what we're all concerned about, and how much that'll grow. And so these common specialty categories, the immune modulators, your Enbrels, Humiras, Taltz, listed those on there, and the diseases they treat: multiple sclerosis, oncology, HIV, asthma, COPD, and then you have a variety of other categories. And then, of course, we know that that's the snapshot today. We also know that the pipeline that's coming is just completely full of these types of agents. And so we know that that's what we have in front of us. So next slide, please. One of the things that I mentioned is that, we know about biosimilars, and we had indicated, or I had indicated earlier, that we have access to medical claims, and we're able to enter into rebate contracts on these biosimilars, and we've selected exclusive agents in all of these categories. And so we've chosen one product, and we've secured exclusive rebate contracts on these. That's added a lot of rebate revenue, and it's helped reduce the cost on the medical side. Doesn't really show up on the pharmacy side, but from an overall perspective, it's been effective. The one thing I'll note here is that none of these, the FDA, none of the biosimilars are considered interchangeable. However, even doing the exclusive, we've not gotten a lot of pushback when we've selected an exclusive agent. And if someone wants to go outside of that, we have an exception process, prior authorization, appeal process that could be managed to help reduce the number of non-formulary products that are being covered. So let's, I guess we can go to the next slide, but I just wanted to mention the biosimilars there. The gene therapies, again, it's in the title of my talk. I'm not going to spend a lot of time here other than we use the same process that I defined earlier to evaluate these drugs. I think we have to. These treat catastrophic, just horrific conditions. And so when you're talking about children in wheelchairs for the rest of their life, this gets your attention, and you want to make sure that you're making the right decision and giving them something that will work. The only two drugs currently that we cover on this list are Provenge and Yescarta. We evaluate the evidence there. For years, we excluded Provenge until some evidence within the last few months surfaced, and then we opened up the policy to allow us to cover that for metastatic castrate-resistant prostate cancer. But the remainder of these, we pretty much exclude just because the evidence has been weak or inconclusive. And we'll continue to look at these, as time goes along. I think the other thing, too, that Cheryl touched on is the financing of how these drugs work. It needs to be a discussion like Zolgensma for the spinal muscular atrophy, $2.5 million per year on that. Next slide, please. I'm trying to zip along and because I don't want to go over time, but address any questions here at the end. But one thing I wanted to touch on that's very essential that I never thought would until I got into state government, that will make a huge difference. And you all on the phone or the conference may know this way better than I do, but make every attempt that you can to know and have relationships with legislators in your state governments and federal governments, and educate them on what you do and what your company does, how your company impacts the economy, and what your workers do and how they think and what your fears are. That's essential to this whole process, because there's this legislative process going on outside of your building that can devastate your plan, and you won't even know about it till it's too late. And so this year was a very heavy legislative session in Arkansas. 36 bills, healthcare related bills were enacted. And a lot of times, most of these are well-intentioned, but there will be components of what these bills address that could have severe unintended consequences. And I just listed 4 bills here that, one that requires, this very well-intentioned senator put this bill out there that said, if clinical practice guidelines are in existence, then prior authorization requirements would be approved, or drugs would be approved if they're supported in clinical practice guidelines. We worked with that senator to insert the language or published peer-reviewed literature, just like I spoke of several slides ago. We can, and she understood how our program worked, and she had no idea that would have gutted our entire prior authorization process. So she was very willing to insert language. This second one on the cost sharing amounts paid by enrollees, basically what this thing was intended to do was to force employer groups to give credit to these patient assistance programs to patients. And so that $2,000, like if you had somebody on a high deductible plan and they were paying $2,000 for a particular drug, that you had to give them credit for it toward their maximum out of pocket or their deductible, whether they paid it or not. And so that would have gutted our accumulator program, worked with a sponsor on that. Basically, the law says if Ebrx is managing your prescription drug program, you're exempt from this law. And so just an example of working with the legislators to help circumvent some issues. That third one, that's the only thing I'll mention there, but some legislator thought it was a great idea to outlaw rebates paid on insulin products. That will cost the state $8 million this next year, and we're working with legislators right now to have that overturned, and we believe we will. But that was one that passed in the absolute 11th hour of the session. No one knew about it until it became law. And so that's just to amplify, get involved in your legislative process, because it can pay dividends for you. Next slide, please. Kind of just wrapping up here is that we do all these things and prior authorizations and all these creative things that we do, and we've been doing them for years. It sounds great. And, you know, sometimes I feel good about it, but then you look at the big trends, like it's still going north. And so all these efforts, you know, what does it mean? The one thing I wanted to shift gears on a little bit, and I guess we can go to the next slide. But one of the challenges that we have is that physicians and patients do not know the cost of these drugs that we're paying for. They really don't. They'll tell you that. And so the question would, you know, what if providers and patients had all of the transparent information to make good decisions? And you had that in front of them in an efficient way. And then wouldn't it be nice if those decisions, the right decisions and the savings that the plan could enjoy would be made between the patient and the provider? And so the work that I've been involved with Gemini, and the reason I bring this up is out of the almost 40 years I've been doing this, I see this model as a game changer. Now, currently, there's an overarching or kind of a popular benefit called real-time pharmacy benefits, or Rtbc, a lot of acronyms out there. And over half the physicians out there that are using an EHR are seeing costs of medications, but they're not seeing everything. They're seeing copays, the total drug cost net of rebates. They don't see that. There are no incentives for physicians to spend time looking for lower cost alternatives. Can you advance the slide? There's some other, I guess, hit enter twice there and then hit it one more time, because yeah, there you go. And so a lot of times the alternatives, there aren't a long exhausted list, or the alternatives are not relevant. And so anyway, the training that would be required by physicians. And the other thing, proven savings are kind of missing here. Like, how much does this save? The other deal is that this model, the real-time work of the physician in the exam room, all that sounds good. Prescribing is done at the end of the encounter. And so they psychologically moved on to the next patient. And so there's not a lot of time spent. And the other thing is that the real-time pharmacy benefits address new prescriptions. They don't exist, or they don't address the existing prescriptions, so to speak, or the maintenance medications, which eat up most of the cost. So we know on that related note at the bottom there, that CMS 4180, you know, the government's starting to say, look, we need to get some information back out to the hands of the consumers and providers to help make good, informed, transparent decisions. However, the definition of that has not really been solidified at this point. And so anyway, could you go to the next slide, please? The work that I've done with Gemini, they've developed, of course, they provide the real-time pharmacy benefit, you know, in the exam room, the at prescribing, and we've talked about the challenges that has from a timing perspective, and you're dealing with a subset of drugs. Your switches are probably 1% of the total presented. Just some obstacles here that, and I'll just summarize this, is that we have a lack of information, and we have a lack of incentives. I mean, no one's being paid to get their arms around this. Pharmacists, the community pharmacies are, they're in a high volume, low margin model where they're just generating prescriptions just to keep the lights on, and patients, they may or may not have incentives to switch to lower cost drugs. And I saw the lower cost drugs as one of your survey phrases there. And so Gemini's developed, in addition to the real-time pharmacy benefits, a patented drug savings report that is delivered to the physician in the EHR for patients that are coming in that day, so where they can address the existing medications. It's also used through a portal by a managed care pharmacist at a health plan or an employer group to go in and pull the drug savings reports, share those with patients and physicians. And also, just to quickly, I'm running a pilot currently that involves about 50 encounters where I set up a 30-minute WebEx with a physician in California, and I go through the report and walk through patient-specific switch opportunities, and experiencing about where they've agreed to switch about 50% of the drugs that were presented. Each 30-minute session, the things that they've agreed to add up to about $10,000 per session. We're paying them for their time. The model will eventually probably pay them for their time after the session if they do the switch, or spend time talking to the patient. May have some impact on removing or diminishing their prior authorization requirements, which paves the road and puts the incentives for the physicians, also sharing some of that patient or the savings with the patient. So aligning the incentives and also paying pharmacists for their time. And it's a different way of thinking, but I've seen how this works. I've seen the acceptance of physicians. And so just going to the next slide to wrap up is what are the results of this, or how's this playing out? Back in October 15, Blue Shield of California, Gemini's first client that initiated this, about 4 million lives, did a press release announcing 10 million in savings using this approach. And so just hit enter for the next deal. And just recently, or here in May, that number increased to 20 million. So this is not a Dwight Davis infomercial here, but I did not want to pass up to show there are ways that we can address the rising cost of pharmaceuticals. And the other things, we talk about specialty accounting for about 50% of the spend. Let's don't forget about the other 50%. And a lot of those are embedded in this type of arrangement. And so there are lots of savings to be picked up on the table. So that brings me to the end, and I apologize for just running up to the end of time here, but I would certainly entertain any questions or follow Cheryl's lead on how we should handle that piece of it. But thank you for your attention.
That was excellent. Thank you so much, Dwight. I've got several questions, so we're not going to rapid fire them. We have about 15 minutes, but more may come in, so let's just make sure that we're leaving a little extra time if needed. One of our first questions was, can you confirm if your accumulator program is not charging the member nor while saving money for the plan? You said the member is paying a $5 copay. Is that in every case through the accumulator program?
That's correct. Yeah, we've set it up, we've designed it that way where the patient, now it could be that, I think the maximum amount might be $20, but those might be a small percentage, 1 or 2 drugs, but most of them were either 0 or 5. And that piece was important to demonstrate to the legislature that we were in no way passing cost back to the patient, or saving money on the plan at the expense or to the expense of the patient.
Okay, helpful. Are specialty drugs covered on coinsurance in your plan design? And do you pass rebates onto the patient for specialty drugs?
the first part, yes, they're covered. So if the patient has a high deductible plan, the specialty drugs apply to that as well. And I'm sorry, what was the last part?
Last part was, do you pass rebates onto the patients for specialty drugs?
We currently, the 100%, and this is a little bit different model, is that 100% of the rebates go directly back to the plan. So we don't have the capability at this point to do point of sale rebates. The plan uses those rebates to reduce premiums, or at least that's what we're told. But when the manufacturer sends the payment information back to us, we pass that completely, so they can see to the tabular capsule what those rebates were. They pay us to provide that service, but 100% goes back to the plan, and they can handle them however they want to.
That's great. Would you consider the EBRX review process to be similar to the Institute for Clinical and Economic Review, or ICER's approach?
Well, it's an interesting, the chair of our P&T actually serves on an ICER panel. And so we use a lot of the ICER information and cost effectiveness data in our decision-making process. So yeah, it's a data point, but yeah, we consider it good process.
Excellent. Anybody who has additional questions, send them in. We've still got some time. What can employers do to eliminate rebates and transition to value-based contracting?
Well, we've gone down that pathway, or at least in full transparency, we have no value-based contracts, because I'll be honest with you, and maybe it's we're early into the discussion process. We've talked about value-based contracts to several manufacturers. None of them have, or they appear to be unsure about how they even want to structure a value-based agreement and what data elements they would require to make that effective. So we currently have not gone down the pathway. We understand that rebates, and for that matter, the accumulator program, it's a shell game. We get that completely, and and that's why that was the intent of some of that legislation that was passed. But the reality is, we've kind of taken the stance that we're going to play the game as long as it's being offered. We don't want to shut it off and then miss and chase something else that might not replace the rebates. But currently, we've not found a good solution to follow the value-based approach completely. Hopefully at some point we will, but we haven't done that yet.
Well, I know with our Employer RX Evolution program, Denise will talk about it later. It's about contract optimization. It's got value-based, of course, elements in it. But if you don't have that foundational piece, which you do through your contracting, you really can't do anything. So one of my questions as we talk about rebates and transitioning to value-based contracting is, what would the right type of legislation look like? Because we've been trying for 12 years to have an impact, and we have brought a ton of information to the hands of the employer. We've uncovered the bed sheets, or whatever term you want to use, skeletons. We've been transparent. They've changed their contracts, not just because of our project. They have consultants and others that help, but we've been extremely transparent. And you get to a point where you realize maybe legislation is the only thing that's going to have an impact. What would the right legislation for the top two issues look like? And I would say the top two issues would be, I know you don't want to get rid of rebates, but it's fake money, as I like to call it. It's a tax return, if you will. What would the right legislation be for that, and also for transparency?
Wow. I think, and honestly, I've always made the statement, and we've seen it and experienced it here, and being involved in the legislature here, we've rapidly come to this conclusion, is that we want to be careful what we want to be legislated, because it's kind of a double-edged sword. It can be heavy-handed, and it can create some unintended consequences. And I always make the statement, I'm thankful to live in a country where drug companies can do exactly what they're doing. I also want to live in that same country that I can say no. And as long as, and just like that, the legislation that basically tied our hands or was attempting to tie our hands on using peer-reviewed published data to make coverage decisions, as long as they will allow, the legislation will allow us to operate freely and use the evidence that's been published and the best evidence to make good decisions and not mandate us into paying for drugs at zero copays and all these things without proven benefit. I think that's a first step, is allowing latitude to do the drug evaluation, because that's where it all starts. The other thing is that I'd say the value-based contracts, it seems like most of the conversations that we've had have centered around adherence, which spells increased utilization, which means they win and you don't. We want something more. And so whatever those clinical outcomes that the drug needs to demonstrate, that's what should be incorporated in a value-based agreement. So if you say your drug reduces cardiovascular events or reduces hospital stays, and let's figure out a way to prove that and put that in the contract. So I think it's a balance, but I guess the only point I was going to make on the legislation is price fixing would be a very slippery slope, I'm afraid. And so I've never really thought that would work. But I guess the short answer to the question would be, I really don't know what the perfect legislation would be, but I do think that, just from our perspective, from a self-funded employer group, if we can be given the latitude to do what we do currently, I would be happy, because every session challenges our existence, and you have to go explain that over and over, and then you can see the light bulb come on. But the pharmaceutical industry is the most powerful lobby in the world, and they're going to continue to push these things to gut the plan's ability to effectively manage their cost.
And the PBM and the hospital and the other are the largest in the country. And so you've created a model that had to work around the system, right? You're not a PBM.
No.
You've created a model to work around the system, and unbundling that model would be difficult for you. We totally get it. So I'd love in the future for you to say, yeah, if we did this or we did that from a legislative standpoint, it would be good to know how it could work. I totally agree with where you're coming from. And often when we've got legislation, it's got a bunch of other stuff thrown in that just doesn't make sense, like, giving patients their rebates at the point of sale and those kind of things. Do you contract directly with manufacturers for rebates, or are you using a rebate aggregator?
No, we contract directly with the manufacturer. So we have, for every rebate contract we have, it's directly with the manufacturer, and we go out and pursue those individually based on the design of the formulary. So there's not a pass through, and that's what we wanted, a transparent, every penny accounted for. Our finance people here at UAMS keep pushing me, hey, well, wish you would have negotiated a percentage. It's like, well, then transparency flies out the window. I'd rather be paid a flat fee to do this and pass 100%. And it passes, we built it to pass a legislative audit. And it's been audited by the legislature, and no findings. And so that's exactly what we wanted. But yeah, now the other piece to that is that we are looking at the drugs that we do not contract, let's just say the crumbs on the ground, so to speak, that allow the PBM to do an aggregation. If they can pick up an additional, $1 million or whatever, that's great. But the core group of drugs that we pursued on our formulary, we want to control those contracts directly.
I have 3 questions, and we have 5 minutes, so I think we could do it. What about international drug price benchmarks? Would they work to lower prices in the United States, in your opinion?
the real answer is I don't know. I know it's been tossed around. I think the only concern I would have would be the unintended consequences, just because our health systems are different. And I think, you know, I do, with all the challenges that we have, and maybe, you know, there may be plenty of people on the call that disagree with this. I still think we have the best healthcare system in the world, with all the warts and scars that we have. I still, you know, I think that, you know, comparing our prices to other countries, you know, may have some unintended consequences, but the real answer is I don't know.
That's fair. What do you recommend to employers when pharmacogenomic testing confirms the right drug that is not one indicated by your system?
Well, I think that anytime that our approach doesn't match with something that's clinically appropriate, that we have an exception process and we evaluate that and make appropriate changes to the policy as evidence surfaces. And so if we encounter a situation like that, you know, we would address it. I will say that we've had reports come into our call center that the pharmacogenomic test was done and it indicates one of these three antidepressants are the only ones that'll work. Well, it's never the generic. It's always the most expensive branded drugs. And so we question, I think pharmacogenomics has a lot of, you know, sex appeal, so to speak. But at the end of the day, you kind of have to look at the clinical relevance of all that. But we would vet that out in peer-reviewed data. And we would have an exception process to deal with those situations.
Can you re-explain the difference between Rtbc? I'm not sure if you know what that acronym, and Gemini Health Drug Cost Transparency Tool. Well,
yes, the drug cost transparent. They call Gemini refers to their product as DDP, or drug cost transparency prescribing. That is their model of the real-time pharmacy benefit checks. The difference that I've seen is that most Rtbc, or whatever acronym you use, only shows the copay. So it's a limited amount of information. The physician does not see everything, like the total cost or savings to the plan, or, you know, net of rebates. Gemini's product shows it all. And so that's the primary, but the model is, or that particular service is delivered to the physician through the EHR at the time of prescribing. So it's just different name, but same delivery, but more information shared.
Helpful. So this is my last question. The majority of employers in this country are using traditional PBMs, whether it's through their health plan or independent. We know that they're all merged these days anyway. What are the top one or two things the average employer that really doesn't have the clout? And many of our members struggle with this. Others, the jumbos and large, are more progressive, demand what they want. But what can the average, what are the top one or two things the average employer can do to work with their PBM to make a difference?
Gosh, you know, that's a tough one. But I'll just say, as you were, because size matters. I mean, it really does. And when we're talking about this topic, I would say the good news, I mean, and that's a struggle, but I just say the good news that everybody that's a part of this group, I mean, I would encourage that every employer group in your geographic area be a part of this coalition, this group, and use your clout as a, you know, although you're a small or average employer group, you can act like a huge, you know, that's kind of what we try to do with our state agencies. Some of these groups are 2,000 or 3,000 lives, but they hook their to the wagon of the state employees of 160,000 lives. And now when manufacturers come to the table, that's over a $200,000 block. Well, in Arkansas, that's a huge deal. In Chicago, that's a small deal, but I'd say the one thing that you could do is join forces as a group, because you have the mechanism to make such a difference with these average or smaller employer groups just by solidifying and consolidating and speaking with one voice. I'd say that would be the single biggest thing. And then you could develop a kind of like what Denise did in Fort Smith, was create this model that everybody kind of joined in. And you'll have some individual thought and differences there, but by and large, your philosophy and your DNA resonates across the organization. So I would say that'd be to me the most logical way to address that.
Well, that was a great closing. And I always think to myself, if you're not part of a coalition, is who you're listening to giving you the truth behind what's going on. And our large and jumbo members that are leading the charge are still talking to each other. And our smaller to mid-size, 500 to 5,000 or even 10,000 are learning from the larger and more progressive employers. So I can't thank you enough. I love your transparency. I love your honesty. I love your innovation in looking at things differently. We've known you for a long time. When I introduce Denise, I'll explain the Arkansas connection so she knows. But we look forward to continuing to collaborate and work with you in the future, Dwight. This was outstanding. And we just thank you very much.
Well, thank you, Cheryl and Denise and the Midwest Business Group on Health team. And it's a pleasure to work with you.
Sounds like a plan. Wonderful. Thank you so much.
Thank you.
Have a great day.
You too. Thank you.
All righty. If you'll put the next slide up, I'd appreciate it. Fantastic. We actually have a couple minutes, but I'm going to go ahead and introduce our moderator for the next panel on employer trends. Leading trends. Denise Giambalvo is MBGH's VP. She's been with us about 2.5 years. And prior to coming to MBGH, she was running our sister coalition in, as Dwight said, Fort Smith, Arkansas, and running a program that was really cutting edge that Dwight was engaged in, and working with a lot of leading not intermediaries, consultants and suppliers that were doing it right, that were doing it for the benefit and only for the benefit of employers and their families. So why don't we go ahead and get started, Denise, by you providing any opening comments you want and introducing your panel.
Thanks, Cheryl. Hi, everybody. It's great to be here today with all of you. That was a fabulous start to our morning. Dwight never disappoints us. I learn something new every time I speak with him, and I hope that was how it was for you this morning. Our next panel of employers will be bringing some more great knowledge to you. So I'm going to jump right into it with them, introducing Kim Forster. She's the Director of Pharmacy Account Management for Blue Cross Blue Shield of Michigan and has over 20 years of healthcare experience expanding across various markets. Prior to joining the Blue Cross team, Kim was a vice president for a prominent pharmacy consulting firm and facilitated pharmacy vendor contracting negotiations and oversight to ensure accountability on behalf of health plans and self-insured employer groups across the United States. And Kim is here today to present with Demi McBride, who's Manager of Health and Welfare Benefits for Ford Motor Company and serves in a leadership role on Ford's Global Wellbeing team. Demi joined Ford in 2015 and has 19 years of healthcare industry experience. Prior to Ford, Demi spent 13 years at Truven Health Analytics, now IBM Watson Health, serving as the account executive for many large employer clients, both private and public sector. So with that, if we'll go to next slide and turn this over to Kim and Demi.
Hi, everyone. This is Demi McBride. I'm going to get us started with the presentation. Thank you so much to MBGH for inviting Kim and me to speak with all of you today. We're really excited to tell you about the partnership between Ford and Blue Cross Blue Shield of Michigan, which is focusing on transitioning our members to biosimilars. So you showed up for today's session on prescription drug strategies. So that means that you likely already recognize that prescription drug spending is a really important area of interest for healthcare purchasers. They are a significant portion of our healthcare spend at Ford. It's about 22% of our total spend across the medical and pharmacy benefit. And there are some alarming trends in this space, particularly with specialty drugs, which are the fastest growing area of pharmacy spend. They comprise 60% of our total RX spending. There are very few scripts, relatively speaking, but much higher prices. And the utilization of these specialty medications is going to continue to grow because of the robust pipeline of new specialty medications. I've heard that it represents about 3/4 of the total pipeline. And so the fact that prescription drugs, including specialty drugs, are delivered under both the pharmacy and the medical benefit further complicates things for purchasers like us. There are nuances and unique challenges to addressing prescription drug spending under the medical benefit. And one important area of focus for us is biosimilars. So Kim's going to tell you much more about biosimilars, but they're like generic drugs, but for biologic products. And since they are designed to be highly similar to the brand name reference product, which means they can be clinically substituted. And we care about this because they're often much lower in cost. Because most of the reference products with biosimilars are delivered under the medical benefit, we, the healthcare purchasers, must partner with our medical carriers, not necessarily just our PBMs, on a biosimilar strategy. So that's why I'm here presenting with Kim, who is representing our largest medical carrier, Blue Cross Blue Shield of Michigan. They've been really trailblazing in terms of their biosimilar strategy, and we here at Ford have really benefited financially from our partnership with Blue Cross in this space. So since I'm not a pharmacy expert myself, Kim is going to take the lead on the technical aspects of the presentation, and I will comment along the way about Ford's experience. So with that, Kim, I'll turn it over to you.
Perfect. Thank you so much, Demi. Really appreciate that nice introduction. Demi and I thought it might be a good idea to level set on what a biosimilar is, just not assuming everyone fully understands this space. So on the next slide, we just tried to highlight for you that you should think of a biosimilar like any other new product to the market, right? Any biosimilar has to go through the same rigor with the FDA as any non-biosimilar product. They're safe for patients. There's plenty of studies and outcomes that prove effective equal efficacy and safety for patients. So they're good solutions for our members, like with Ford. And it's also important to highlight that the biosimilar products still have to go through the post-market surveillance to ensure continued efficacy and safety, just like any other drug. So biosimilars are a growing focus for us, as Demi pointed out, and we're very excited about the progress we've made with our strategies related to biosimilars in partnership with Ford over the last couple of years. An important thing to kind of point out, I guess, with relation to biosimilars is a biosimilar is not interchangeable with the innovator product, like our friend Dwight mentioned a few moments ago, compared to a generic product, which is interchangeable. So this requires a little bit more finesse when you're looking at strategies for biosimilars in relationships with your providers and being highly considerate of the member experience and the whole launch of the program. And because a biosimilar is using live organisms, right, to base that product on, compared to a generic drug, which is using synthesized chemicals, you have to look at every biosimilar situation and every strategy per biosimilar very differently and uniquely. So if we want to move forward to the next slide, we'll kind of give you a little idea what the differences are and like thoughts to consider when you're looking at a biosimilar strategy. I can tell you for Demi and I, we prefer lowest net cost strategy. There are other biosimilar strategies that are more rebate driven, meaning you're chasing the rebate, you want that big fat rebate check at the end of your strategy, your tax return, as Cheryl mentioned, where we didn't take that approach, right? So we're looking at what are the opportunities to look at specific drugs that have biosimilar equivalents in the market, and where can we pursue that lowest net cost strategy. The lowest net cost strategy You have to consider, obviously, what the contracting relationship is going to be. What kind of improved discounts are you going to get? What kind of improved rebates are you going to get? And a lot of that is determined by the volume of biosimilars available for any innovator product in the market. How you're going to position it in your strategy. Are you going to create parity? Like for us, when we launched Neupogen in October of 2020, Neupogen we kept with parity with a biosimilar product. For that particular drug, that's what made sense. Every drug, again, is very different because the situation is different from a contracting standpoint. So we took a look at the market and where we had biosimilars available for us here in the United States. We have 29 biosimilars approved to date in the U.S. And from those 29 biosimilars, 17 of those are for oncology drugs. So obviously oncology has been a little bit of a wild, wild west historically in trying to change or manage costs with oncolytics. I think with the advancements of biosimilars in the market, we have new opportunities to provide cost savings without creating that disruption. So on the top 10 list, you'll see like 2 of those, obviously, we mentioned were drugs with innovator products in the market. Interesting that shortly there behind, we had 2 cancer drugs, predominantly treating breast cancer, Avastin, Herceptin. Most people are very familiar with those. And interesting, like Demi pointed out, from a medical benefit standpoint, #1 drug spend for us was Remicade in 2019. So these are obviously our hot targets for our biosimilar strategy, but when you're looking at a lowest net cost strategy, there's a lot of considerations. You need to look at, as Debbie pointed out, are the drugs covered underneath the medical benefit and the pharmacy benefit, like we see with Neulasta or like Neupogen, like I mentioned a few moments ago? So your strategy is going to be a little different when you have coverage under both pharmacy and medical for a particular product compared to the others Demi mentioned or that are listed here that were also on Dwight's slide earlier in his presentation. They're covered predominantly on the medical benefit. You need to look at side effect profile. We are very sensitive to member experience. We are very sensitive to disruption for our members. So we always look for, low-hanging fruit. Anything that's going to create a lot of disruption for a member, we try to avoid. So side effects are an important piece of that. And then obviously, like I mentioned, the savings approach. You got to look at overall savings, not just look at the additional rebate opportunities that are available. And a lot of, like, again, the model you choose to pursue for your strategy determines, where those opportunities are for savings. And so looking forward, I'm going to give you a little snapshot of how we launched the program. So you can go to the next slide. Thank you, Denise. So as I mentioned, for us, Remicade represented about $140 million in spend for us on the medical side. Annually, we were looking at about 23,000 infusions a year. It's big. I mean, it's huge dollars. And it was an easy target. So Remicade has actually multiple biosimilars available in the market. The one that seemed to dominate here in the US and in the European market was Inflectra, which is a Pfizer product. So we took the approach of partnering in making Inflectra our preferred product. So our strategy for Inflectra and Remicade was a little different maybe than some of the oncolytics that we mentioned on the previous slide, but for this product, we really needed to work super closely with our provider community. And I think one of the reasons Blue Cross Blue Shield of Michigan has been able to be so successful in our biosimilar launch was because of provider relationships. So we were able to work really closely with the provider community long before the program launched. So we were getting buy-in from the prescribers writing for Remicade to ensure they were going to support the strategy before we officially launched it, to ensure that super smooth transition to the biosimilar product, the Pfizer product, Inflectra. So, our approach was very focused on provider outreach, member outreach, which I think was a big reason why our program was so successful. I'll give a shout out to my friend Demi, because obviously the outcomes they had in some of their plans was even better than what we had at Blue Cross. So Demi, I think you were going to chat a little bit about the success with the Ford members with our strategies that we rolled out together.
That's right. I get to cover the good news part of this. So as you can see in the table, we had overall outstanding results, both for Blue Cross at the book of business level, which are the top two lines, across their HMO and their PPO populations, as well as for Ford. And actually, our results at Ford were better than Blue Cross's book of business, and we're really proud about the 100% transition rate for our HMO population. Kim tells me that we're the only client group that Blue Cross had that achieved 100%, so that's pretty exciting. And I think because of Blue Cross's thoughtful rollout strategy, as Kim mentioned, engaging the physicians in advance, not disrupting patients who are mid-treatment, and also, a really strong communication strategy. Maybe the best part about this is that we were able to accomplish this with literally no noise from our membership. So that's a real pride point for us. And should be, something that gives you guys hope if you haven't embarked on a biosimilar strategy. So since implementation in 2019, starting with Remicade, and then through April of 2021, which is our most current data, and that's after Blue Cross expanded the program to include 5 additional biosimilar drugs, we have achieved close to $5 million in total savings, which is really great. So we'll go to the next slide now.
Yeah, that's real money, Demi. No one bats their eyes at almost $5 million. So I think one of the key themes, and I should have mentioned this a little earlier too, especially with the drug that we targeted, Remicade, it wasn't just because it was our highest spend drug or one of our highest spend drugs on the medical side. It really was because of the outcomes and the success of Inflectra in the market. So on the slide a little earlier, I had mentioned, Inflectra launched in 2016. It's important to note that our friends in Europe have been using biosimilars since 2016, and we've been much slower in the US to have access to the FDA-approved biosimilar products. And that is because I think Dwight mentioned this as well, the litigation that happens to protect their patents. To kind of give you an idea, you look at a Lipitor, and when Lipitor launched as generic, Lipitor had 1 patent, right? When you look at a drug like Humira, Humira has over 100 patents because of all the different indications now for Humira and different forms of administration. So it takes much longer for us to gain access to those. I think it'll be really important moving forward to keep those things in consideration. We are all crossing our fingers and our toes that by 2023, we're finally going to have access to the biosimilars for like an umbrella and a Humira in the US market. And then that integration thing is going to become a little more important to look at when you're looking at your strategy. So for us, the things that we can do to help manage, we like carrots rather than sticks. So we prefer to incentivize our provider community by giving them, different, adjusting their fee structure, right? And cost of administering a biosimilar product versus the innovator product, an easy way to, again, incentivize. Once you get to a place where you're shifting market share and you've already got the provider community to buy in, it's easier to consider a exclusive option like Dwight talked about, or moving to a preferred option, which is the approach we have taken through all of our biosimilar initiatives. And obviously the lowest net cost strategy, I think, is an important thing to emphasize too, because for us, we're not looking at just the rebate opportunity. We don't chase the rebate. Rebates are super important. They're big, and the financial impact of those are definitely a consideration, but we need to look again at the whole picture like we talked about, the different considerations to look at to ensure whatever we launch into the market is actually the lowest net cost strategy that's going to, again, create the least amount of disruption like Demi pointed to based on the experience that we had with Ford. So, for us, we are, again, member-centric, so we have allowed, I call it grandfathering, but really what we did when we launched the additional 4 products that are either the white blood cell modifiers, the cancer drugs that were on the slide previous to this one, is we looked at the approval. All these drugs have PA requirements. So we extended the authorization for 6 months. So looking at transitioning all new members to the new products, to the preferred product, right? The biosimilar for most purposes except for Neulasta and Neupogen. And then for members that were on current treatment pretty much ensure that they can complete their initial treatment. And then if that treatment was to be renewed, then we start them on the preferred agent, which in most cases is the biosimilar product. So we're going to move forward to the next slide. And Demi, I just want to close with a couple of little thoughts for you to consider as you're looking at potentially launching a biosimilar strategy for your members.
That's right. And I'll go first with the employer's perspective, employer plan sponsor's perspective. So first of all, pharmacy strategies and pharmacy benefits in general they're very complicated. And it's easy to feel discouraged as a non-expert in this space. I sometimes feel discouraged. My word of advice is don't let that stop you from asking questions of your partners, your medical carriers, your PBMs, if you have consultants in this space. Ask them to show you your data. Inquire about what programs they have available. Understand where they're innovating on behalf of plan sponsors. And if you're not happy with what you're hearing, push them to do better. Consider hiring an expert pharmacy consultant. So, as we've already discussed, there's significant savings potentials with biosimilars. So this is an important topic to bring up with them. And then finally, as I already alluded to, the member experience is really important to us. And for those of you like us that work with unions, you know that it's paramount to unions as well. And we have 55,000 UAW represented hourly employees. So you can design these programs thoughtfully so as not to put the member in the middle. And I just suggest that you advocate for this. So like Kim mentioned, consider doing limited grandfathering so that you're not disrupting patients who are in the middle of their treatment cycle, and ensure clear communications to members. And then I know Kim is going to address again how Blue Cross found success by focusing early on engaging the provider community, listening to their concerns, sharing data and evidence, adjusting the program in some cases based on their feedback, and then ultimately securing their support, which really helped with the smooth rollout. Because as you guys know, your members, the patients really look to their physicians to reassure them. Kim?
Yeah, thank you, Demi. Yeah, thank you. And again, just to kind of restate some of the things we already talked about, like Demi highlighted for us, we started working with the provider community 6 to 12 months before we launched the strategy. We ensured we had buy-in from the prescribers that are writing for the products we were initially targeting, and obviously expanded since then, to make sure that we weren't going to hit adversarial situations with the providers, because we don't want the member to be in the middle, right? We wanted the prescriber community to be well informed and be thinking forward when they're writing new prescriptions. I know Blue Cross is going to be preferring the biosimilar. I got a new member starting. Let's start them on these biosimilars sooner, right? So that there's less, potential for member abrasion. So there's a lot of focus on that. This is a great initiative, because again, to Demi's point, members not in the middle of this one. So a really important to consideration, like whoever you're rolling your biosimilar strategy out, to understand what's the approach. Are they going to cut a member off? And if they are, ensure effective communication. Because again, we are alike mind, Demi and I, on the importance of ensuring, the least amount of disruption for a member as possible. And then understand the strategy. Understand, are you going to be chasing the rebate dollars, or are you looking for a lowest net cost strategy? And then make sure you understand all the dynamics that are involved in that for each biosimilar, right? Because you can't just rip the Band-Aid off and say, we're always going to prefer a biosimilar, because I think you'll be missing opportunities. Again, they're not just like generics. And obviously this is a incredibly clinically supported program, ample evidence to support the move to the biosimilar products and to support a biosimilar strategy. So moving forward, we're really excited about the pipeline. There are a lot of biosimilar opportunities that we're going to continue to explore. And a lot of those now are going to be more of those drugs that fall on both sides of the benefit. So it'll be important to have alignment with whoever's managing your medical benefit and whoever's managing your pharmacy benefit as these products become available. So we appreciate it. Thank you for your time. And we'll be hanging out to answer questions for you guys later.
Thank you, Kim and Demi. So we have some questions here for all of you. And I will start with Darcy and Demi. you're both relying on others' expertise to direct you on your pharmacy benefit decisions. So how do you discern what information to listen to and what to table?
I guess I can go first. As I already mentioned, I am not an expert in pharmacy, so I absolutely rely on the expertise of our partners, our carriers, the PBM, our pharmacy consultant. I think for me, the first step is always education. So I ask a ton of questions to deeply understand the problem that they're trying to solve with the program. What different options are available? What have they considered? And I want to know their decision-making criteria. And I want to understand both the potential upsides and the potential downsides of anything we might do. I also, you may have heard in my bio that I have a background in healthcare data analytics, so I always ask for data. I expect our partners to be willing to peel back the layers of the onion for me. And I ask for guarantees around the future success of the program. If a partner feels strongly enough that a program is the right thing to do, I think they should stand behind that as well. And then finally, I talked about member experience earlier. Navigating healthcare is hard enough as it is for our members. That the healthcare system is difficult to navigate. Benefits are just inherently complex. And so I'm always going to want to know what steps we can take together to really create a smooth experience for the member. And then I guess kind of the final consideration is, if we decide it's the right thing to do, the question is when and how does it fit in with everything else that we have going on, other strategic initiatives.
Is there anything that you heard that any of you heard this morning from Dwight that kind of made you went, oh, I've got to dig a little deeper into that?
So I can jump in really quick. Darcy and Demi are still collecting their thoughts. So I am a big fan of Dwight's. I've known him a long time. Super fun to see that. Had an opportunity to follow him. He's brilliant. I agree with you, Cheryl. Great guy to have providing advice. So I was grateful that he was teeing up kind of what Demi and I were trying to cover. So it was nice to see that he's already addressing biosimilars, and they're doing very similar work that we did collectively with Ford. Their approach is a little different, right? They were going full after the exclusive option, which nothing wrong with that. It's just a different approach compared to our approach, which was more focused on lowest net cost, which doesn't mean his approach didn't result in lowest net cost options. So I would be very interested in, learning more from our perspective on how they pursued that. Again, with our sensitivity to member disruption, it wasn't an option for us out the gate, but would be something we'd be very interested in pursuing, as part of our future strategies.
Thank you. Darcy or Demi, anything you'd like to add?
Well, I'll just add, I really enjoyed Dwight's presentation as well. Many of the things he covered are topics that are on our radar. We've been in discussions with our partners and are thinking about, as we're making a transition in terms of our PBM contract. I'll say a topic he touched on, which I'm very passionate about, is looking for opportunities to eliminate waste from the formulary wherever possible, by excluding no value drugs, implementing other programs to address, sort of the big pharma schemes related to, kind of holding on to the brand drugs, bringing forward new drugs that don't add any value. They're just new combinations where generics are available, or changing the packaging. And so that's been something we've been really focused on for the last couple of years, and will absolutely be a part of ongoing discussions with our consultant and PBM.
Great. Has State Farm or Ford considered ICHRA as a potential benefit option for your employee-sponsored healthcare?
We have not for our active benefits, but it is something that we've thought about for certain retiree groups.
State Farm has not considered that at this point.
Thank you. Okay, so This person saw the PR about Blue Cross Blue Shield of Michigan being part of the 5-plan organization for profit company called Evio. How is that work going to differ from your current cost containment strategies around specialty pharmacy?
Glad you're paying attention. So we are excited about this opportunity to invest and I guess partner more closely with 4 of the other Blues plans. It is very early stages. The hope is that collectively, the focus on the programs will be to complement the clinical initiatives we have out today. We're not looking to replace PBM. We're not looking to build our own PBM, but just looking at where are there opportunities to take some real world evidence, look at opportunities to build upon that, improve the opportunities for value-based contracting. That was something Dwight touched on too. We, like Dwight, have struggled with it. A lot of the requirements for value-based contracting are based on outcomes data that is super difficult to get on a timely basis. So hoping that through this effort, things like that will create opportunities to improve the value-based contracting. So it's going to be like a little bit of an incubator to just truly be innovative in what we can do to support what each of us, all 5 plans, are doing today. But again, not looking to replace any of our contract relationships we have with our PBMs or other vendors that we've worked with to roll out solutions, but just really looking to be different and innovative and look outside of the box. So more to come, and thank you for paying attention.
What strategies have you put in place for gene and cellular therapies?
So I can tell you for us, only because Demi and Darcy are shaking their heads, and I know Dwight checked on this as well. This has been a big focus for us for years. Dwight mentioned he didn't cover Zolgensma. We do cover Zolgensma. It's one of the first drugs. Luxturna was the other one that we got early hits on. We have our own P&T committee, so we have to be focused and prepared to address the pipeline. There are opportunities with some drugs that come to market where there are lots of other therapies in market that you can rely on, so you can see how the market's going to respond to it, and then you may delay deciding where you're going to fit that into the formulary or to the drug list or to your utilization management. Those products were big hitters. They were blockbuster drugs. They are treating rare conditions, and we have a huge population. So within weeks of approval from the FDA, we actually got requests for the drug. So gratefully, we had already done the reviews, the studies, just like with our biosimilar strategy. We are working with the provider community, the ones that are experts. I can tell you when we first got our first CAR-T request, gratefully we had done our homework. We had no one in Michigan that could administer the drugs. So we had already negotiated with those that are certified outside of the state and had prepared to transport the member to an out-of-state provider to administer the product because of the complexity, right? It has to be administered in the hospital setting. So for us on all gene and cell therapies, it is a strong focus. We actually have separate P&T focus for specifically around the gene and CAR-T therapies so that we are prepared when they come to market. If they are the blockbuster, no other option in the market, obviously ethically, as a health plan, we're required to provide coverage. Still working on the cost concerns, right? They're expensive, astronomically expensive. And so still working through the myriad of options that are being discussed in the market on how to continue to afford to cover the cost of these drugs, because stop loss alone is not going to be your solution. So yeah, big focus for Blue Cross Blue Shield of Michigan is to continue that work. And like I said, we've got a whole focused P&T effort on the gene and cell therapies that are in the pipeline.
But the sound should go away shortly. I am excited to introduce our next speaker. So if we could pull her presentation up, Achieving Outcomes Through PBM, Specialty PBM and Medical Services Carve-outs, which is such an important topic. Amy Ball is the Chief Pharmacy Officer at Health Strategy and is responsible for the clinical strategy of the organization. She helps self-funded employers and health plans make sound clinical and economic drug coverage decisions while maximizing the value of their pharmacy benefit. We are also so pleased that Health Strategy is one of MBGH's purchasing partners. Are you with us, Amy?
Yeah, I'm here, Cheryl.
Welcome, and thanks for your patience and flexibility in moving things around this afternoon.
Sure.
Go ahead and get started as soon as your presentation comes up. There we go. Awesome. Thank you.
Good afternoon, everyone. Hope you enjoyed your lunch. Appreciate the opportunity to spend some time with you today talking about pharmacy and medical benefit. We've had a lot of good information shared today, and I think what I'm getting ready to share with you sort of wraps some of that up with an actual client example of the results that they've had to date, implementing some of these strategies around specialty pharmacy and medical pharmacy management. So sort of reiterating some of the stuff Dwight and others have already said today. Overall pharmacy trends have been low in the single digits to negative in some cases over the last few years. But even in those situations, specialty drug trend continues to grow, and we've seen that across our clients. Generally, more than 50% of plan spend is for specialty drugs. We have worked really hard over the years with our clients to manage that non-specialty drug spend very low. And so most of our clients have a specialty drug spend in the 50% range because non-specialty has been driven so low. Some of the leading conditions that are driving that spend, as we've talked about already today, inflammatory conditions, certainly, oncology, HIV, multiple sclerosis. And if you look at the IQVIA slide that I've got on the screen, the bottom axis is the 5-year growth, and the left axis is the 1-year growth. So from 18 to 19 for 1 year and 14 to 19 for 5 years. And you really see there's only one non-specialty category that even competes with what we're seeing in some of these large specialty categories, and that's diabetes. But oncology and autoimmune disease are really driving a lot of the spend on the specialty side. So there's a lot of strategies that you can look at to mitigate specialty trends specifically, and we're going to talk about some of those. Formulary management, distribution, channel, day supply management, copay assistance programs, and then medical specialty management. And we've talked about some of these already. I'm going to go into a little bit more depth and then give you a client example and show you the savings that they've realized by implementing these strategies. Next slide, please. So when you talk about formulary management, and I think Dwight did a great job of explaining what they're doing around really full custom formulary management. Health Strategy does have clients where we do full custom formulary management. That's making every single drug coverage decision. We offer our clients a quarterly webinar where we look at all new drugs to market. And so not just for those custom formulary clients, but now an option for all of our clients to really take more control of their formulary management. So if you look at the left-hand side of the slide, the current state of the market is a PBM controlled formulary, where the PBM is making all formulary drug coverage decisions. Many times the incentives for those PBMs are to add drugs to the formulary to drive rebates, and we've talked about that today as well. The problem is you as an employer client have no transparency to true net cost. I think Dwight directly contracting with manufacturers, managing that custom formulary, that's where you get that true line of sight. Now, I will tell you there are some PBMs out there that will give you true line of sight to your rebates so that you can then figure out your true net cost. A lot of times with the PBMs, you'll see bundled rebates where then those patent extension type products, those low value drugs that we've all talked about, get added to the formulary automatically. Products with short patent lives are not preferred over the newer agents because they're pushing that rebate strategy. So it's really important to begin to take more control over what you consider covered under your formulary. We get into the other area of PBMs creating and administering prior auth criteria, as well as owning those pharmacies where those drugs are being dispensed. And you begin to create all these conflicts in the marketplace about whether the criteria are aggressive enough, whether they're being approved to make a profit on because they're going to dispense the drug. And so there's ways to mitigate that. There's partners certainly you can work with to help decrease some of that conflict of interest. As we move to what health strategy considers the future state, this is where we think employers should be making their own drug coverage decisions. And with the quarterly webinar that we do in working with our clients, we created 3 formulary philosophies. So low control, medium control, and high control. We're not marketers, so it's not fancy naming convention, but looking at how employers want to consider making their own drug coverage decisions. Are they adverse to member disruption, but they don't want silly drugs added to their formulary? So there's really low value, no added clinical benefit drugs added to their formulary. We would call those the low control decision makers. Then we have the high control decision makers, which are very aggressive and very much aligned with Dwight and their philosophy. So these are our clients generally who are full custom formulary. They're making aggressive decisions on a lot of these new therapies, especially specialty drugs, oncology, many oncology drugs coming to market under fast track approval. Dwight highlighted the comment in the package insert, and every time we do a quarterly review of these new drugs, we highlight that in our review process so that people understand how these drugs are coming to market as well. Then you have the medium control folks who kind of sit in the middle, and they don't want to disrupt their members significantly, but they also don't want things like patent extension products, line extensions added if there's no clinical value and no improved outcomes. So there is a way to manage your formulary, take more control without being a full custom formulary, but making decisions on new drugs as they come to market, because that's when you get ahead of the curve. You don't have members getting on those drugs. You put a new drug to market block in place with your PBM so that there's no negative member impact. So it's sort of like a closed formulary, but you have to make those decisions quickly before the PBM puts those drugs on their formulary. So we've had great success. Many of our clients now involved in making those decisions for themselves and managing their formulary, taking over some of that control from the PBM. Next slide, please. And why formulary management? In the past, a lot of low-value drugs coming to market in the non-specialty space. But I wanted to give you this example of some formulary new drugs recently around MS, because this really points to the specialty bucket and why it's also important to manage your formulary as it relates to these specialty drugs. So if you look at some of these recent specialty brand and generic launches for MS, a great example is Kesimpta. Kesimpta is a CD20 directed cytolytic antibody. It has the same mechanism of action as ocrelizumab, Ocrevus. It's indicated for the treatment of relapsing forms of multiple sclerosis that include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. Ocrevus has that same indication, and Ocrevus has one additional indication as well. Kesimpta is the 15th disease-modifying drug that the FDA has approved for RRMS. It's the 4th agent for self-administered sub-Q injection. So you have beta interferon 1B, which is beta-therone Xtavia. You have interferon beta 1A, Rebif and Avonex, glatiramer, Copaxone, and Glatopa. The benefit of Kesimpta is being self-administered. The problem
Amy, can you hear us? Can you hear us? We can't hear you, or at least can others of you hear her?
No, we cannot.
Okay, Amy, can you double check that you're off mute? She might have to have restarted. So we'll just wait 1 second for her to come back. Thank you for those of you on the call reminding us that you also cannot hear her. As you know, sometimes it'll kick you out. It did it to me yesterday, and there we are. And she'll be with us in just a second. You can see her trying to connect. You can see her face, she's moving. We're just trying to connect on the audio. And thanks for your patience, everyone. Yay.
Sorry about that.
No problem. That's okay. That's okay. At least you didn't have a grimace on your face, you know. All right, you're back. Yeah, thanks so much.
I think it must be the makers of Kesimpta. Just dropped me off there. The benefit of Kesimpta is that it's self-administered, but it is more than twice as much as Ocrevus. And so when you're looking at these therapies, exact same mechanism of action, same outcomes. Kesimpta is $135,000 for the first year due to the loading dose, to $100,000 a year thereafter. Ocrevus, IV infusion, so it is not self-injectable, 3 infusions per year. The first year, you split that first dose 2 weeks apart, and then every 6 months thereafter. The annual cost of Ocrevus, around $67,000. So when you start to look at these therapies and look at everything that's coming to market, you have to look at it as a whole class as well. And so when we did our new drug to market review for Kesimpta, we recommended excluding that product because Ocrevus is available as well as other products to treat relapsing remitting MS. I want to talk about 3 other drugs in this class as well. Bafratam, which is monomethyl fumarate. It's a fumarate type drug, as all 3 of these next 3 I'm going to talk about are. It was approved via the 505(b)(2) pathway. So if you're not familiar with the FDA approval process, the 505(b)(1) is the traditional pathway. The 505(b)(2) is really an accelerated pathway that allows you to base your efficacy and safety on the package insert of an already available drug on the market that is very similar. And in that case, it was based on the package insert of Tecfidera. And so Tecfidera's prodrug form, not systemically detectable following administration. So Bafratam achieved approval on the basis of bioavailability equivalence to the monomethyl fumarate levels attained after Tecfidera administration. Tecfidera runs about $84,000 a year for oral therapy. I'm sorry, Bafratam runs about $84,000 a year, and it is an oral therapy. Vumerity, also an oral therapy, runs about $100,000 a year. It also was approved via the 505(b)(2) pathway via Tecfidera as well. And Vumerity is a prodrug of dimethyl fumarate. So we know Tecfidera is dimethyl fumarate. The generic now of Tecfidera is available and runs about $12,000 a year. And the price is dropping. We're seeing continual price drop of that generic in the market. $12,000 a year is probably on the high end. But again, that kind of depends on your contract, and we can talk a little bit about that as well. But brand Tecfidera runs about $120,000 a year. So when you look at the price that these drugs are coming out at, they're all similarly priced, kind of in that same, $70,000 to $120,000 a year. And now we have a generic available on the market that now, with competition, we're starting to see that price drop. What's important about your pharmacy contract is that if you don't have separate generic pricing that is aggressive and guarantees that are aggressive, the PBM can price that in a way that makes it not price effective. So we'll talk about some of the other strategies that we've implemented in the market to help decrease that reliance on the PBM for pricing of your drugs as well. Next slide, please. Distribution channel and day supply management. Probably most people are at least already doing some of these things. So from a distribution option standpoint, you can use the PBM-owned specialty pharmacy. This is where, your contract, if you're going to do that, needs to be very specific about those generic rates. We are seeing more and more generics come to market on the specialty side, and you want to make sure that you have aggressive pricing in place. You have the option, if you can get that in your contract, and we do that for our clients, to carve out under a direct contract for specialty pharmacy distribution services. You can do that on an AWP discount basis, and if you do that, again, if you're going to do a direct contract under AWP as the costing basis, just ensure that you have aggressive generic discount guarantees. because that requires then those pharmacies to give you their best rate on those generic drugs. Otherwise, you're going to pay a price similar to the brand drug, even for the generics. The other option that we've got in the marketplace, and we are doing this with specialty pharmacies, is cost plus pricing. Cost plus pricing removes you from that AWP costing basis, where we know that AWP and generic pricing, the acquisition price of generic drugs, do not correlate. And because of that, under cost plus pricing, we can get very aggressive pricing on generic drugs. And that is the same for specialty as well. So that is an option to carve out your distribution to a separate specialty pharmacy that's not related to your PBM. The other option is carve out PBM services completely for specialty pharmacy services, and that's a completely separate PBM. And in the example that I'm going to show you for the client, we've actually done both, where we've carved out PBM services, so 2 PBM model in place, and we've carved out specialty pharmacy distribution. So we'll talk about both of those in terms of how those benefited the client. Channel management, looking at an open specialty network versus an exclusive specialty network. Many times, if you don't get the right language in your contract, you don't have the ability to determine what a specialty drug is. If you retain that right, then you can have an open network where you send certain drugs to your specialty pharmacy. That can be PBM owned, carved out, et cetera, and certain to your retail network based on where you get the best pricing. If you don't have that in your contract, it's probably best to go with an exclusive specialty network, because generally you will get better pricing that way. And certainly when the PBM owns a specialty pharmacy, they're going to give you better pricing to use their pharmacy, because that is a big profit margin bucket for PBMs today, is the dispensing of specialty drugs. They won't give you as good a pricing when you allow that to be an open specialty network and allow retail pharmacies and others to fill those scripts. So if you are bound by that contract, looking at an exclusive specialty network could save you a couple hundred basis points. It's not going to change your trend at all, but it will save some on your spend. When you look at day supply management, limiting fills to a 30-day supply is important. I absolutely, as a pharmacist, understand that 90-day supplies can help with adherence, but these are very, very high cost medications. And so we always recommend 30-day supplies. You will see some of the PBMs that allow 90-day supplies of these medications. And depending on your turnover of your employed population, that may not be a good thing for you. Certainly some of these drugs require a 90-day supply or greater because of their dosing frequency. And so obviously that is absolutely allowed, but your PBM has to be able to do that correctly. We've had some who, send over all the information and they all say 30-day supply when we know they're actually longer day supplies, but it's a setup issue. So you have to make sure all that's set up right as well, so that when you're looking at your data, you're looking at it correctly. Next slide, please. Copay assistance programs. This has been a really interesting opportunity.
We can't hear you again, Amy, but we can see you. Let's sit tight for a second. Okay, she's going to log back in. Appreciate that. That's what you do when you speak a lot. You just bite the bullet and flip back in. Again, folks, sorry about the disruption. There she is. Give her a second. You're back, Amy. Thank you.
I'm going to try computer audio this time. My phone seems to keep dropping. I'm not sure why.
No problem.
Okay, but copay assistance has been one of these tools that really anyone can access. And I think Dwight did a great job of explaining how the accumulator program works. There's basically two different options for copay assistance, and you can employ one or the other or both. And the example that I'm going to give you for this client, we have employed both. We started with true accumulators very early on and added the variable copay program in 2019. So these programs, the variable copay program allows savings for not only the member, but the plan. And that's really important because there's money out there being provided by the manufacturers for these products, and allowing the plan to save money on that is a benefit. The true accumulator file is extremely important if you have a high deductible plan, because as it exists today, if you don't have these programs in place, when those members access copay assistance under a high deductible plan, there is no way for you to know that they've used that copay assistance program and the full amount of their calculated copay applies to their accumulator. It allows them to meet their deductible and out of pocket quicker, and therefore the rest of their healthcare is free for the rest of the year. People, employees know about these programs, and they know how to use those programs to enhance their benefit and get a lot of the rest of their healthcare for free. We've actually had people call in to some of our clients directly to the HR department and say, I understand you're changing PBMs now. This isn't going to change the way my Humira card works, and I'm still going to get the rest of my healthcare free for the rest of the year, right? So they understand how the programs work. And that is probably the biggest hurdle. If they're used to allowing those to accumulate and you take that away, that's probably where you get the most noise. But we've really had limited noise when we've implemented these programs. Copay assistance has been extremely successful at lowering plan spend on specialty drugs. It is, and you'll see that in the example that I show, it has been fantastic at doing that. We don't know how long these programs will last and how long it's going to be before regulations come into play to somehow limit the utilization of these programs. But for the time being, they are there and they're very successful. And you'll see that they have significant savings for members. We just implemented a 23,000 life plan with a smaller PBM that offers not only specialty copay assistance, but non-specialty copay assistance. And they found a way to do that pretty seamlessly. And that client just started in 2021. And to date through May, based on total cost, they've saved 14% off of total cost for their non-specialty drugs and 33% on their specialty drugs. So it's been fantastic on both the non-specialty and specialty side. In 2018, Reuters estimated 17% of employers with more than 5,000 lives were using copay assistance programs in their plan. And we're seeing significantly more PBMs today offering these programs, and they've improved those programs. The big three were sort of behind in some cases on these copay programs, and we've seen them step up and improve those programs where the savings is pretty significant. If you look to the right, and this is 2020 data about the utilization of these accumulator and copay maximizer programs, and what you see in green, the dark green, are people who have widespread use of these copay programs. So we are seeing that increase. And then if you look at those that are using just for specialty, you've got about 40% in both cases, accumulator and maximizers. So definitely more people are stepping into the copay assistance programs, and there's some real savings associated with that. Next slide, please. Medical specialty management, we've talked a lot about that as well. The folks from Ford and State Farm, working with the Biosimilar program. Oftentimes, this is happening on the medical specialty side. It's estimated that about half of overall specialty drug spend is under the medical benefit. So if 50% of your pharmacy spend is under the specialty bucket, double that, and you're having basically that exact same spend on the medical side as well. So there is a lot of opportunity on the medical side, and you can get as much savings there with just a few members impacted than what we're even seeing on the pharmacy side. So there's a ton of opportunity. I call this the wild, wild west. There's a lot of things that have to be evaluated on the medical side and a lot of opportunity there. We're going to continue to see the opportunity in medical specialty continue to grow as the pipeline continues to grow. We're seeing more high-cost therapies come to market for rare diseases, and certainly a lot in the oncology space. When you look at the Magellan 2020 medical specialty trend report, it showed a 14% increase in PMPM trend for medical specialty drugs from 2018 to 2019, and their 5-year trend was 58% from a PMPM perspective. So we're going to continue to see that grow, and that's definitely something that everyone needs to start considering and finding partners to work with around medical specialty. Top drivers of trend in medical specialty seem to be oncology and the oncology support meds, and that's where we see a lot of biosimilars, as well as autoimmune disease, and then we're seeing this rise in Ocrevus, certainly for the treatment of MS on the medical side. Strategies to mitigate trend in medical specialty: dose optimization, vial rounding, weight-based dosing, site of care, copay assistance, and then managing duplicate billing. So there is a complexity when a drug kind of crosses both of those pharmacy and medical parameters that you've got to be able to manage and make sure that a physician isn't double billing something that has been processed through pharmacy. So certainly a lot of things to look at there and a lot of opportunity, and I think you'll see that in this next example. So if we can move on now, I think the next slide is the example of what we're seeing with our client. So this is a client, this is the trend history for this client. This has been a health strategy client. This individual employer has been a health strategy client since 2009. We've done a lot of things with them over the years, a lot of what I've already talked about in terms of things you can do to help manage your spend. And in 2010, we implemented a custom formulary with them and implemented a new plan design. Prior to that new plan design, they just had a flat copay, same percent, all drugs, no tiers. So we took them to a very different plan design, 4-tier, co-insurance, min-max, and then implemented a full custom formulary. So the client, along with health strategy, providing the clinical support and the data support, we manage and do still today manage a full custom formulary. In 2011, after an RFP process in 2010, we moved to a new PBM. And you can see that if you look closely at the dark blue lines, which is our client, and the light blue lines, which is the PBM book of business, PMPM, plan paid PMPM, this does not factor in rebates. We were continuing to see cost increases from 2012 to 2016. And when you look at what was driving that, a lot of that trend was specialty. So in 2017, we looked at, we did another RFP, moved the business to a PBM that we were able to work with that would allow us more flexibility, that would allow us to do some of the creative things that we needed to do to be able to get our trend managed. And then in 2019, we moved to the 2 PBM model where we did the specialty PBM services carve out with copay maximizers and accumulators. So this is the long-term history for this client. I'm going to dig now into their specialty trend. Next slide, please. This client was not immune to the market changes that were happening at the time. New Hep C drugs came to market in late 13. By late 2014, virtually all Hep C was being treated with these newer agents. 14 to 17 really drove a significant specialty trend. We saw an increase in new drug approvals for rare conditions, hereditary angioedema, cystic fibrosis. We're continuing to see new launches in those categories as well. So when you pull out just their specialty drug trend, plan paid PMPM, we were continuing to see that escalate. And so we knew we already managed a custom formulary and we made very aggressive drug coverage decisions on specialty as well. We had a direct contract in place for specialty distribution, and we had that in place since 2011. We were doing cost plus pricing. We also carve out the direct, we also carve out retail there and mail order as well under direct contracts. We put the true out-of-pocket accumulator tracking in place with this client and the carve out specialty pharmacy and the PBM at the time in 2016. before really a lot of people were doing that. We recognized that early, got that in place early, but the PBM that we had at the time couldn't find a way to use manufacturer copay assistance to help decrease plan costs. So we needed the option to have to be able to implement additional strategic ideas. Next slide, please. So we moved PBMs in 2019. We made sure we had the contractual right to do a lot of different, I'm sorry, in 2017, we had contractual rights to make changes. And when that in 17, when that PBM specialty pharmacy wasn't really, from a PBM perspective, wasn't really helping us manage specialty, we looked at implementing a total specialty PBM carve out. And this PBM that we use for specialty does not own their own specialty pharmacy. And we already had a direct contract in place for distribution. We put a focus on copay assistance to help not only the members, but the plan. And you can see what happened to our spend. A 25.5% reduction in plan paid spend PMPM. So we went from 2638 to 1966 PMPM. And we've maintained that as we went into 2020 and certainly continue to maintain that in 2021. In 2020, then we implemented medical management for specialty drugs, and we started with non-oncology drugs. So not wanting to rock the boat in the oncology space, started with non-oncology. We delegated the prior auth, copay assistance, site of care management, medical rebates, and post-adjudication checking for duplicate billing, appropriate dosing, et cetera, to that specialty PBM. And so I'll show you some results of that, I believe, on the next slide. Now in 2021, we've expanded, back just real quick, I got 2 more bullets on that last one. We've expanded the medical carve out to include management of HIV medications. We're going to access additional copay assistance there, as well as the oncology products and support products. So we're trying to pull every lever that we can to maintain our flat to negative trend. Last slide. When we implemented the specialty PBM carve out, virtually no noise, no issues. It's been pretty seamless for the last 2.5 years. Copay assistance drove the majority of our savings. I'll walk through those savings numbers, but you can see them over there on the right. Savings for both the plan and the member. Clinical savings, we vetted, the health strategy vetted the way that this PBM documents their clinical savings and how they take credit for that. So if a member is no longer eligible, the savings stop. If a member switches drug or starts back on a therapy that might have been denied via a PA, the savings are no longer calculated. The savings calculations, the clinical savings are real. And so that has been impressive. We go through cases on a quarterly basis of implementations, interventions that the PBMs made with our members. Copay assistance in 2020, and I did not think this was possible, grew by $1 million. Now, granted, our total cost has continued to go up, so we're continuing to have utilization of products, but we're able to lower our overall trend. And copay assistance certainly has had a big impact on that. Half of the growth was from medical specialty drugs that moved under pharmacy, under billing for pharmacy. Clinical savings also grew in 2020 pretty significantly. So if you look to the right under 2019, and this was just specialty pharmacy, and this is a client in the size range of 30,000 to 40,000 lives. And we accessed $2.3 million in copay assistance just on specialty drugs. It was 20% of the total cost of specialty drugs. Clinical savings were $950,000 in that first year, and that's 8% of total cost for specialty drugs. In 2020, we saw that grow. Copay assistance has grown to $3.3 million, now 24% of total costs for specialty. And our clinical savings in 2020 was $2.7 million, 19% of total costs for specialty. And with the medical specialty copay assistance, we were able to access the medical side, working with a TPA that is very flexible and very willing to work with us. We saved $564,000 in copay assistance. The clinical savings was $352,000. Site of care, another $500,000 in savings. still a lot of opportunity inside of care. So again, we did more of a carrot than a stick, but there is significantly more opportunity around site of care, and we intend on finding more ways to access improvement inside of care. And then only 88,000 in billing errors, got a really good TPA there that does a very good job. So we found limited issues with duplicate billing. So about 1.5 million total on medical specialty. So this client has pulled what I consider to be many levers in managing their specialty spend and trend. So all of these things are possible. Any client can do it. You may have to go to RFP to get those contractual rights to be able to do some of these things. And even if you can't, I would say reach out to your PBM and make sure you're involved in copay assistance, especially around specialty drugs. A simple change of your SPD, you can get that program rolling. So hopefully this has been helpful in understanding some of the levers you can pull, as well as seeing the results that we've had with some of our clients.
Thank you, Amy. This has been great. We have limited time for questions, so I want to jump in for clarification on something that was in the chat and then came through as a question, and that's on the Kesimpta versus Ocrevus. And I believe the prices you were quoting, that they're based off of a specific employer and what they were seeing. Is that correct? And what was in their claims? What?
On Kesimpta?
Yes.
So we excluded Kesimpta upfront. So for most of our employers, they didn't have utilization of that. So we would be basing that off of a WAC or an AWP based pricing.
Okay. So so there's a correction here in that the WAC cost for Kesimpta is $83,000 before rebates. And so, and you may have to go back and look at this, but would that change your recommendation with preferring Ocrevus after you factor in the infusion costs for Ocrevus, or did you already factor that in?
Yeah, the infusion costs into the 67,000 are, they may or may not, I'll have to go back and look, but I believe we factored those in. They're generally minimal compared to the price of the drug, and especially when it's only twice a year. So I'll go back and look at that, and I can send you a chat just on the pricing afterwards.
Sure, that'd be great. We have, let me see, we have time for one or two more questions, and then I will email some over to you for you to,
that sounds great.
Respond to, because there's so many good ones that came in. But will the large PBMs ever weigh their 25% fee for implementing copay coupon savings?
Highly unlikely. Now, you can negotiate that, I think. We've been able to negotiate with some PBMs and get lower fees. But when you're talking about $1 million, just for every $1 million, if they're taking 25% of that as a fee, you're still saving $750,000. So depending on the size of your plan, it's probably a good give at this point. I don't see them doing that as the potential for rebates, lowers as more generics come to market. It's another revenue stream for them, and they're being upfront about it and indicating what that percent is. Do I like 25%? No, but I really don't see the big PBMs moving away from that. When you work with some of the mid-level to smaller PBMs, you can get a better percent. You're getting access to the same copay assistance, but you can certainly get a lower fee. And we've been able to do that.
That's good to know. And do you have some large to jumbo employers that are working with mid-size PBMs?
We do. Yep.
Okay. I know in the past we had some who had concerns that they wouldn't administratively be able to manage their size.
Yeah, and I think it depends on what you want them to do for you as well. And so if you want the flexibilities that I talked about, you're gonna almost have to go to a mid-level to get those flexibilities. A lot of people will tell you they'll give you that flexibility, and then when push comes to shove and you try to get things implemented, it's significantly harder. So we have large employers, over 100,000 lives, that are using mid-level PBMs. Again, I just placed a 23,000 life. I don't call them jumbo. We call them small, with a smaller PBM, a very small PBM. And it's been very effective. We have you won't believe this, but we have a negative 42% plan pay trend through May. Wow. It's been phenomenal.
Phenomenal. That's the exact word that was in.
Yep.
Phenomenal. So wonderful. Well, we'll end there. I'll email the additional questions to you.
Okay.
And then if you want to put them into the chat or you want to send them back, and I'll get them out to everyone. We can.
That's great.
Okay?
And I apologize for all the technical issues.
Oh goodness!
My phone never loses reception in like 20 minutes.
Yeah. Well, our annual conference started like almost 90 minutes late last month because of technical problems. So you're forgiven, and it's out of your control too, right? So there's not even need for forgiveness.
And
Cheryl,
Amy,
yeah.
Thank you for your flexibility. That was really awesome that you were willing to move your time up, and I'll explain to everybody what's going on, but don't even worry about it. And like Denise said, after starting, the first day of our 41st annual conference 90 minutes late and not knowing what was going on, this was easy peasy. So we appreciate it.
Absolutely.
Thank you so much. Thanks, Denise. So I want to tell you what's going on. We have a couple of speakers that had to move things around, unavoidable. And so, which is often what we do behind the scenes, is we move the agenda around. So that's what we've been doing behind the scenes. And we're going to next, Lori, if you'll pull up our next sponsor message, we're going to hear a message from Reliance Rx. And then, which is something she may not have known we were doing. So if you just want to advance to that slide. And then we ask that you just take a 5-minute break, so that at about 1:35, which is getting us back on schedule, sort of, we can rejoin, and we greatly appreciate that. Until Lori has an opportunity to pull that slide up, I'm just going to share that now our employer panel will be around 2:30, and that will go to about 3:30. And then you will hear a message from Judy about what's going on in the marketplace with insulin for diabetes. And then also Denise will share her presentation, which was going to happen, I think, right around now or shortly, on what MBGH is doing with Midwest Health Purchasers Collaborative, with the various resources and point solution vendors that we're working with, but also a little bit about the project information that we're doing. So excellent. And Lori, go ahead and start the ad. And then guys, afterwards, take 5 minutes for a break, and then we'll be back at 1:35. Thank you.
At Reliance Rx, our mission is to provide the highest quality specialty pharmacy experience for our customers, all while promoting positive patient outcomes and efficient use of specialty services. Our focus is ensuring that our clinicians and operational staff are mindful of the impact that even the smallest intervention can make on a plan sponsor's bottom line. Our opt-out, custom internal patient management program, RelyRx, has produced a cost savings of over $25 million since its inception in 2013. Reliance Rx is not driven by shareholder investment. We are founded on the principles of ensuring the lowest net cost by working hand in hand with customers to formulate a specialty pharmacy strategy. Rated the #1 best small company to work for in New York in 2020, Reliance Rx values the interactions our staff have with your employees every day, knowing we are at our best to ensure necessary interventions are achieved. At Reliance,
what are some examples of how employers use data? And she shared thoughts with us. So can you give us the previous panel? This isn't the employer panel, Lori. This is our 130, 135, using data to find where the savings is hidden, the panel right before this. Thank you. Ways that we as employers use data to identify opportunities to impact drug spend, to match medications to individuals in a clinical and financially appropriate manner. And another is using it for the annual review of our results. I know we're going to hear plenty more from our speakers about what they've done and how employers can use their data to find where savings is hiding. I think this is absolutely critical, not being in a transparent world, and we need to get to a transparent world. So I'm going to start by introducing all three panelists. They will each have about 12 minutes, 13 minutes to share their thoughts, and then we'll move to Q&A. Antonio Cheche, and I know I'm going to say it wrong. Denise has said it to me 3 times. Antonio Checha, I think that is correct, Antonio. You have to correct me if I'm wrong. Is the CEO of 46 Brooklyn. His data work was instrumental in exposing pricing distortions in the Ohio Medicaid managed care program and prompting state officials to audit their prescription drug spending through the program. The findings uncovered that more than $244 million was being hidden through PBM markups, and that is in just 1 year of Medicaid drug spending. This set off a tidal wave of scrutiny and reform in Ohio, but eventually is extrapolating, to other states across the country. I've heard Antonio speak a few times, and he is fascinating, and the story is excellent. Our next speaker is Jonathan Levitt, who co-founded the boutique healthcare law firm of Fryer Levitt. Beginning with a 2003 national class action lawsuit of independent pharmacies, he began his journey to both understand all aspects of the drug space and develop skills relevant to multiple stakeholders. He has dedicated his practice to representing pharmacies, physicians as dispensers, national provider associations, manufacturers, wholesalers, and plan sponsors. Jonathan has an established track record of challenging abusive pharmacy practices. And finally, we have my friend, I almost said old friend, my friend Tom Traylor. We've known each other for a number of years, is the Executive Vice President of Business Development at Archimedes, and he has spent his career working on the cutting edge of healthcare benefits. He has served large employers and Taft-Hartley groups and held multiple leadership roles, including most recently serving as the Chief Product Officer and General Manager of the Health Transformation Alliance. I would like to welcome all three of you, and we are going to start with Antonio, and then we'll go into panel. Welcome, Antonio.
Great to be here, Cheryl. Thanks for the intro.
Say your last name.
It is cha-cha, just like the dance.
You know, if they would have said that to me, I would have said it right for sure. Let's pull Antonio. I'm sorry. Let's pull Antonio's photo up here, Lori. And I appreciate you clarifying that for me, cha-cha. That cha-cha. Yeah, that would have been easier. All right. Thanks and welcome.
Thank you so much. Do you all have my slides already?
No, we definitely need to pull those up.
There we go. Perfect.
Thank you.
Well, look, it's a pleasure to be with you all today. I am the CEO of 46 Brooklyn Research, which is a nonprofit dedicated to making drug pricing data more accessible and understandable to the general public. That's what I do with my spare time. I started a consultancy after we launched 46 Brooklyn because we were bombarded by plan sponsors, lawyers, and provider groups, really everybody across the drug supply chain, from those who dispense it all the way up to those who pay for it, because they were looking for answers to see if we could diagnose the problem, maybe we could cure the problem. So we launched 3-Axis Advisors in the beginning of 2019. We do work for state Medicaid programs, Medicaid fraud control units, law firms that are litigating in this space. We also do a lot of research projects all across the drug supply chain and the continuum. So, and we've also started working on some disruptive market-based solutions. As we'll discuss today, there are a number of problems in this system, and there are a number of ways to cure them. Legislation, litigation, and market-based solutions are all probably a 3-pronged strategy, generally speaking, that I think needs to be deployed to rectify the wrongs that are embedded in this system. Next slide. So we'll start with the most basic and fundamental question. What is the price? Next slide. The key is, which price are we talking about? Unfortunately, in the US drug supply chain, there are a variety of layers and a variety of benchmarks and proxies that you can use to describe a price at any given moment throughout the system. What you see here is just a sampling of the different types of alphabet soup that are available out there that you could use to quantify or derive the actual price of a drug. Next slide. Unfortunately for payers, plan sponsors, the drug prices are proprietary. They are hidden. And your exposure to cost and a patient's exposure to cost are largely derived from very complex contracting relationships that exist within the supply chain that are all proprietary and not necessarily lending themselves to an efficient marketplace. Because prices are not objective, they are prone to manipulation. Next slide. And unfortunately for all of us, the system is built on fake prices. List prices for prescription drugs are wildly overinflated relative to their actual cost. Even though we all know that, PBMs use those list prices, usually based as some percentage off of average wholesale price or AWP, or in the pharmacy world, we jokingly like to say ain't what's paid. Unfortunately, it ain't what's paid, but it is what's billed. And they use AWP as the basis for their pricing guarantees to both pharmacies and plan sponsors. Brand name drugs have high AWPs that are offset by negotiated rebates and discounts that have been much discussed. Generic drugs also have high AWPs that are derived from brand name drugs that in no way reflect the actual prices that pharmacies pay to acquire those drugs. In both regards, the real prices or the market clearing rates for those drugs are both hidden to the plan sponsor and the patient. Next slide. So we're going to talk a lot about the fallout of fake prices. We do a number of data analytics projects throughout the drug supply chain. A lot of our work started in Medicaid because that's where the initial bomb went off in our involvement in the supply chain. But we've gone a lot further than that. We've started analyzing commercial data and Medicare data as well. Both the previous slide and this slide showcase essentially how PBMs are handling distribution and utilization of certain medications. So we've done research in the commercial space and in the Medicaid managed care space. In fact, a lot of states that we've looked at in the Medicaid space specifically. And usually what we do is we rely upon a lot of publicly available data, at least in the start of our research, to start diagnosing where we could find dysfunctional prices or obscenely high markups within the drug channel. In the Florida Medicaid program, we had a unique opportunity that, and not only were we able, in previous work, we had relied upon CMS state drug utilization data, which is aggregated data showing what state Medicaid programs across the country on a state-by-state basis are being charged for every drug. Uniquely in Florida, we did a public records request. My background is actually journalism before pharmacy. And so we got 350 million claims worth of data from the Florida Medicaid program, where we were able to see day by day, drug by drug, pharmacy by pharmacy, plan by plan, PBM by PBM, exactly what the reported rate of reimbursement was for each pharmacy claim over the course of about a 5-year stretch. What you can see here is a sampling of that data. What you see here is that for the 4 largest plans, all name brand plans in the state Florida Medicaid managed care program, you could see that with brand name drugs, for claims that are under $2,000 per prescription, a very small segment of those prescriptions are actually being dispensed by pharmacies that are owned by the PBM or managed care plan. But when you get to prescriptions that are over $2,000 per prescription, you see that a disproportionate share of those prescriptions are being filled by PBM-owned pharmacies. The chart to the right shows you what the problem is when that happens. When you aggregate all the data across all the brand name drugs and analyze the AWP discount at traditional community pharmacies versus PBM-owned pharmacies, you could see a 2% difference in general off AWP. It is more expensive to fill these medications at PBM-owned pharmacies versus a traditional community pharmacy marketplace. Next slide. But before anybody fools you with aggregated data and tells you look at the top and don't look in the details, we do the exact opposite. We look at the top, the bottom, and the middle. This is just one example, but I can tell you that this would extrapolate across many different drugs, the exact same data set, looking at the exact same plans, just looking at a singular drug for Humira. The service that is being rendered from one pharmacy to another is not materially different, but as you can see, significantly more expensive when the Humira is being filled at pharmacies owned by the PBM. And as you can also see, 80% of all of those prescriptions for Humira were being filled by the specialty pharmacies owned by the PBM. So regardless of whether we want to pretend or let's give them the benefit of the doubt that PBMs are here to save us money, this is obviously a very concerning trend that if they're fulfilling the actual dispensing of the drug, what incentive do they have to actually provide you a better rate? They will tell you that they're trying to lower your premiums. I will tell you that they might make more money downstream than upstream. Next slide. So those are the brand drugs. Let's look at generic drugs. What we have here is a simple old bottle of generic Nexium. Very old, an old cheap medication, at least it should be. And I have a chart to the right here that gives you a comparison of those different alphabet soup pricing benchmarks. What you see here is that the average AWP for a simple bottle of esomeprazole magnesium, 40 milligrams, is $797 for a 90 count bottle. If you look at the WAC, the wholesale acquisition cost, $162. The national average drug acquisition cost, which is a surveyed benchmark of pharmacies reporting their invoice acquisition costs to CMS, shows that in general, on average, pharmacies are paying $20.70 to acquire a drug whose sticker price is almost $800. The state of Alabama has their own survey where they ask pharmacies what they acquire the drug, and that showed $17.10. I say this to show you that the difference between AWP and the real prices of these drugs are significantly different from drug to drug. I lost my slides there.
We'll work to get those back. Lori,
Cool.
Are you still with us? She might have to reboot.
I have my slides up. I can share them if you would like.
Let's see what kind of a response. Give us just a couple seconds. We'll hope for the best, Anthony or Antonio, excuse me. There's always one thing that happens on a Zoom call.
If anybody deserves to have problems, it's me.
That's very sweet of you to admit that. Denise, what are your thoughts? Should we just give him permission to share his up? Looks like Denise has him up. Fantastic.
So I lost track of where you are, Antonio.
Just go back to slide 10, which is the AWP is a thoroughly broken drug pricing benchmark. There you go. Perfect. So most of you that are looking at your PBM contracts will see that you have some sort of effective rate guarantee, some sort of aggregate discount off AWP. And I'm here to tell you that I would not sleep well at night knowing that you increased your percentage off AWP from one contract to the next. What I have here is that same generic Nexium bottle showing you the average AWP using the green line, the WAC using the red line, the NADAC and the Alabama AAC representing a surveyed benchmark acquisition cost. And what you see over time is that as the number of manufacturers enter the marketplace, those are the orange bars that are moving up, you can see the benefits of generic competition are throttling the real price of that drug down to zero over time. But oh wait, what's happening there to your AWP? I thought competition lowered generic drug prices. Well, no, in fact, it's actually going up over time. That's because as more manufacturers enter the marketplace, they seek to gain market share not by lowering the sticker prices of the drug, but by raising it over time. Next slide. And so when you see your AWP minus X contract, the question you need to ask yourself is, what the heck is AWP? We see routinely where PBMs have language in their contracts that allow them to pick the sourcing of the AWP completely. And furthermore, regardless of whether you have an ironclad definition around what source AWP is derived from, remember that different drugs have many different prices. And the exact same of generic bottle of generic Prilosec or generic Nexium or whatever drug you want could have a massive delta between the lowest AWP per unit and the largest one. So what you see here is a bottle of generic Prilosec could have an AWP per unit of 8 cents per pill, or $8, almost $9 per pill. So that what AWP is really important. Next slide. And that's because AWP is designed to increase over time. If you remember one slide in my presentation, I will ask you to remember this one. This is looking at all of the Ohio Medicaid program's drug utilization data, where you can see everything that they bought over a 5.5-year period. What you can see at the blue and red lines is that both the WAC and the national average drug acquisition cost are declining. The NADAC declines at 40% over a 5.5-year period. The AWP of the exact same collection of drugs increased 34% over the exact same time period. Next slide. And all the major PBMs are linking generic drug costs to the one benchmark in the system that is actually inflating over time rather than deflating. Next slide. So because the system is built on fake prices, PBMs are able to use that high top level price and move money around underneath it. The biggest way that we entered in this marketplace was diagnosing what's called spread pricing, something that many of you are already very well aware of. And that is when a PBM pays the pharmacy one rate, bills a different rate, and pockets the difference. Next slide. So that brings us back to Ohio, my home state. As it was mentioned on the onset, we helped create the crumb trail to get the state to bust open the Medicaid managed care books and find $244 million of spread pricing. They were still making money off rebates, specialty drugs, transaction fees, you name it, but just on spread pricing, over $6 per prescription in the Ohio Medicaid managed care program. Next slide. So the big news last week was that part of everything started crashing down on the first settlement that came out of Ohio. Centene, who owned a number of subsidiary PBMs, was forced to cough up $88 million to Ohio, and they have set aside over $1.1 billion to settle charges over their alleged overcharges. I know I have to wrap up here very quickly. So if you could just please advance the next slide. Ohio isn't alone. This is data we found from Michigan, where the cost of the drugs were going down, the pharmacy reimbursements and the margins were going down, but the orange line, which represents what the state was being charged, was actually going up over time. Next slide. Next slide. So the thing that I will call your attention to, and this is something I mentioned at the onset with brand name drugs, and then I would put a bow on it and answer questions later, is that when a PBM has conflicts of interest in the fulfillment of drugs and the dispensing of drugs, you can no longer trust whether or not they have your interests at heart. This is more data that we found in the state of Florida, where after they banned spread pricing, and then after the state, or after Centene signed up with CVS Caremark as their PBM, this is all publicly available data. I don't mean to single out CVS, but this is something that is unique to them in Florida, but not unique necessarily in the market. What you can see here is that the reported rates of reimbursement after Caremark was taking over setting prices in the pharmacy marketplace, reimbursements to competitors fell through the floor, and then reimbursements reported at CVS pharmacies shot through the roof. This is a perfect example of why your PBM is not acting as a fiduciary and can set margins however they want in the pharmacy marketplace, presents a unique opportunity to find savings in the marketplace. And this problem is extrapolated and even more significant in the specialty marketplace. With that, Denise, I will yield my time.
Thank you, Antonio. We're just switching up who's in control of the slides. They'll pop up for you, John.
Great, thank you.
Welcome, Jonathan. Go ahead.
Okay, thank you so much. So, so if you could go to my first slide. The first slide, as it emerges, will be a picture of the industry. By the way, just as a little background, my name is Jonathan Levitt. I founded a law firm 21 years ago that's just a healthcare and life sciences law firm. We represent, as Cheryl mentioned in the intro, plan sponsors and many different stakeholders, including specialty pharmacies around the country. I am a trial lawyer, so many of the issues that Mr. Chacha just talked about, I get to take depositions and I get to ask PBMs the questions about that data that he just used. So a couple things, talking about, so this is a picture of the industry, and it's a picture of a vertically consolidated industry. You have many different plans, but as everybody knows, the biggest three plans are owned by CVS Health, Cigna, and United. So United is a plan sponsor, just like you all are self-funded plans. You have SilverScript and Aetna are huge, Humana is huge, and also obviously Cigna. Cigna, of course, owns Express Scripts, one of the giant three PBMs. Humana owns a PBM. United Healthcare, of course, owns Optum, and Aetna, of course, is owned by by CVS Health, which owns Caremark. So as everybody knows, the top three PBMs process nearly 80% of all prescription claims in the country. The top six PBMs, 95%. Where there's such a consolidation, there really is an opportunity for the PBMs to take advantage in all the things that Mr. Chacha just mentioned: spread pricing, rebate arrangements, and simply paying their wholly owned pharmacies more money. So recently, there's a new commissioner of the Federal Trade Commission. The FTC is an agency of the federal government that helps to address competition in the marketplace. The new commissioner, Rohit Chopra, just made when I say recent statements, I mean a few weeks ago in the May 28th. He said the FTC stood by and watched as PBM industry consolidated to three main giants. These are his words. The secretive kickback practices through so-called rebate walls between pharmaceutical companies and PBMs are worrisome. Large rebates create a wall around lucrative products in ways that squelch out competitors. PBMs are incentivized to select higher list prices for drugs instead of lower list prices for drugs for their formulators in order to collect a higher rebate. And that can explain some of the data that Mr. Chacha just showed on screen. He also said that FTC and Congress must take concrete steps to address the conflict of interest embedded in the structure of the PBM industry. But one of the main points that I'd like to reflect is that self-funded plans don't need to wait for legislation. They don't need to wait for Big Brother or Congress to make moves. Self-funded plans can act on their own. They can negotiate better contracts with PBMs. So a couple other things about this vertically consolidated industry. Each of these PBMs and vertically consolidated giants now owns a rebate aggregator. And in the next slide, I will talk about what a rebate aggregator is. But for example, Express Scripts, Cigna owns a rebate aggregator called Ascent Health. And United Healthcare, which obviously owns Optum, they own a rebate aggregator called the Coalition for Advanced Pharmacy Services. And then you have CVS Health, which owns a rebate aggregator called Zinc. I ask you, why wouldn't Cigna or Express Scripts call their rebate aggregator Express Scripts rebate aggregator? And why wouldn't Optum call theirs Optum's rebate aggregator, to use that intellectual property that they've developed over a series of dozens of years? And so that's probably, they don't do that because they don't want people to know about rebate aggregators. And I ask you, plan sponsors, do you know what your contract says about rebate aggregators? This picture of the industry really tells another story to me, and that is the bidding of contracts, request for proposal. Does anybody on this call think that when United Healthcare goes to retain a PBM for its Medicare, Medicaid, or self-funded plan business, that they put a request for proposal out to Express Scripts or to Caremark? I think not. When SilverScript and Aetna go to sign a contract with a PBM, do they automatically go to Caremark, or do they bid it out to Express Scripts and OptumRx? I think not. These are no bid contracts. What does that mean to the cost of Medicare, to the cost of Medicaid, and to the cost to self-funded plans, and the cost to to patients as well? And so all those things that Antonio just mentioned Antonio Chacha, in the difference in value between what some PBMs are charging for drugs and what should be charged, isn't that the result of no bid contracts? So if you could go to the next slide. The next slide is talking about rebate aggregators. And, I've had people all over the country call me in the last month, saying that they hadn't heard about a rebate aggregator. We hadn't heard about it either until, a few years ago. And because certainly these PBMs don't tell anybody. But you should know that each PBM owns a rebate aggregator, as I talked about in the prior slide, which revealed the picture of the industry. What are the dangers of rebate aggregators? First of all, I urge you all to have your in-house counsel or your benefits team take a look at your pharmacy benefit services agreement. Does your contract tell you that the PBM that you've retained has the right under the agreement to go out and delegate services to a rebate aggregator, to essentially not do the rebates themselves, but to hire another company? Does your contract tell you that the other company, the rebate aggregator that the PBM is going to hire, is owned by the rebate aggregator? What does your contract say about what happens when that rebate aggregator goes out and collects rebates and then takes a large part of those rebates and puts it in their pocket and then gives the balance to the PBM? And then the PBM tells you, hey, look, we have money, we're going to give you 95%. But the PBM is not telling you is that they own a rebate aggregator that just took a huge amount of money out of the system. So we represented a plan, just like your plan, and we tested this theory a couple years ago. We went to the PBM, we said, we don't see anything in the contract that this plan has with you, Mr. PBM, publicly traded PBM. We want to know if you used a rebate aggregator. And they wouldn't tell us at first. Ultimately, we said we're going to file suit, and they gave us information about the rebate aggregator. In this case, the rebate aggregator took more than 50% of the manufacturer paid rebate dollars out of the system and put it in their pocket. And that is going on around the country in Medicare, Medicaid, and for the commercial space self-funded plans. Broward County filed a lawsuit which was settled very quickly against OptumRx, which, as you know from that previous slide, owns their own rebate aggregator. And that case settled very quickly with Optum giving the money back. And if you go to the next slide. So the next slide is just simply one example. And the reason why this is one of many examples. And I think Mr. Chacha used the expression dominoes falling. And he also used another expression, fiduciary duty, which I want to mention about. But all over the country right now, there's a growing awareness by plan sponsors that there's something wrong with the way plans, PBMs, are adjudicating the pharmacy benefit. A lot of it has to do with, Antonio mentioned, spread pricing, paying their wholly owned specialty pharmacies more money, but also rebates. And so in Lehigh, this is a particularly good example because the auditor or the controller in Lehigh County, Pennsylvania, is just a really good writer. And he wrote this story about the rebates, and it's particularly well written. And he says, here's the problem. Here's my recommendation for Lehigh County going forward. So what did he uncover? He said, essentially, somehow the PBM convinced, and there was an insurance company, Highmark, and Highmark retained Express Scripts. Express Script has refused to comment on the story, but somehow Highmark got Lehigh County, Pennsylvania to agree to a fixed dollar rebate. What does that mean? That means that no matter what happened, that Highmark would pay a certain dollar amount per claim to Lehigh. Well, don't you know that once a PBM has the ability to fix a rebate, in that next plan year, the PBM has a massive economic incentive to switch to higher dollar formulary items so that it can only pay a small fixed amount of rebate to the plan and keep the high rebate dollars for itself. So in this case, the Lehigh Valley controller determined that the actual rebates just for 1 year, and this is not a giant plan, that Lehigh, the fixed dollar rebate was $700,000 less than the actual rebates in that one plan year. And they also determined that in prior couple of years, it was millions of dollars more. So what this Lehigh County controller concluded was, and this is a lesson for all plan sponsors for the benefits departments. He concluded that the audit exposes what many of us have known, that our healthcare system is wasteful, lacks transparency, and is subject to the greater greed of pharmacy benefit managers and that are more interested in profit. He also made certain recommendations. He said the next contract, we should do a better job negotiating. One of the things that he wanted to negotiate better was the ability of the plan to audit the PBM. So in this case, he experienced what he called resistance, getting data, which is, the essence of Mr. Chacha's story is getting data, healthcare data about pharmacy benefit transactions. And this controller said, I couldn't get data. I want a better contract next year so that we can get better data. I don't want this fixed rebate. I want an actual rebate, and I want all of it. And he also wants to audit for next year's. Antonio mentioned it. Antonio talked about the dominoes falling. I have to mention again the Centene, what Antonio mentioned. The Centene has reserved, as Antonio said, $1.1 billion and has settled for $55 million in Mississippi, $88 million in Ohio. And every plan sponsor should be aware. What did Centene do? It's spread pricing. It's falsely sending a bill to Medicaid. There's a public agency saying that they paid one dispensing fee when they really paid another. So when Antonio says the dominoes are going to fall, each of the PBMs are definitely on the lookout for more of these type of claims. If you go to the next slide. The next slide just has a couple more examples. Antonio mentioned the first one here, and so I won't get too much into it. That's the $225 million in spread pricing for 1 year by one PBM to state Medicaid. And so and Antonio Chacha did a great job uncovering some of this. The next two parts of the slide here describe the gross to net bubble. And I think that every plan sponsor should understand what that means. Antonio talked about the list price of a drug is going up. You can see it's going up maybe at a smaller rate, but it's still going up every year. In 2020, it went up by 4.2%. But what is the net price? The net price is the price that the manufacturer receives after all discounts, 340B, rebates, off-invoice discounts. And so the gross to net bubble describes the difference between that gross price that Mr. Chacha described as the average wholesale price, the AWP, and the net price, which is the amount of money that really the manufacturer receives after all these discounts. So that gross net bubble on the right-hand piece of the chart, that $175 billion for 2019, that is simply the difference in value between that gross price and the net price. It's essentially made up 2/3 of that $175 billion is the rebate. A piece of that bar graph, a piece of that $175 billion belongs to each plan sponsor on this call today. Plan sponsors should understand that they need a contract that better allows them to audit the PBM and to get a better piece of those rebate dollars. Thank you. I think I've used up my time, so I yield as well. Thank you.
Again, an outstanding and spoken like an attorney, by the way. I think you both said that, yield. So that means that Tom's going to have to say the same thing. Tom, excellent job, by the way, Jonathan. Tom, you are up.
Thank you very much, Cheryl. Very nice to be here, and it's actually great to follow Jonathan and Antonio, specifically because they're setting up what the problem is that I'm going to talk about. Now, I'm going to talk about this in two ways. There's two sides of this for me. One is in my prior life, I was the Chief Product Officer and the GM for Pharmaceutical Solutions at the Health Transformation Alliance. And before that, I was the CEO of a couple of companies that were focused on the cutting edge in pharmacy benefit, everything from reference-based pricing to always getting to the lowest net cost. And so in my prior life, I was a buyer on behalf of jumbo large employers, and you're talking 4.5 million lives that we bought across. So the majority of what I'm going to talk about today is positioned from that perspective of how are these large employers, these jumbo employers, looking at going into the market, knowing some of what Antonio and Jonathan had said. So we could boil it down to, we knew about spread pricing, and we knew of the conflict of ownership when the PBM owns fulfillment. We knew that there was a conflict in chasing rebates and that you actually end up with a higher cost drug. We knew that there was a conflict in terms of rebate aggregators that are offshore companies where you could say it's 100% pass through, but some of it's staying within that aggregator. And we also knew that we'd rather get $0 of rebate for a drug that shouldn't even be dispensed to begin with. So how do we use that information and the data that we have to then move these jumbo and large employers' benefit forward as we focus on taking more control? So when you think about, as you're looking up what questions that I can answer today, I'm happy to answer how we looked at this from the jumbo large employer side. And I'm also happy to answer this because I've transitioned and now I actually work for the company that we hired. And that actually ended up being a welcome transition that wasn't by design, but ended up being extraordinarily beneficial because I believe in what they do. So if you move to the next slide, let's get into how this played out for the large employers. So we knew the following. 7% of the world's population, that's what the United States represents, but yet it's 50% of pharma's revenue. And looking at specialty in particular, we knew that it was getting to the point where it was outpacing everything else in healthcare in terms of trend. And we could look across a lot of sampling of data to see where large employers were sitting in terms of what their spend looked like in specialty. So obviously, no surprise to anybody on this call, we wanted to focus on how do we get to a better specialty arrangement? Next slide, please. So first, you need to, before you can get to the solutions, you need to understand what are the headwinds, what are the problems. And some of these are pretty easy, and Antonio and Jonathan talked about a few of them, so I'm going to go really quickly. Pharma, obviously, like some of the drugs that they're making are extraordinarily impactful and they help people tremendously. And then there are other drugs which are not worth the value, not worth the price that they're being sold at, and all the way to the stupid drugs that you should just never cover to begin with. With one of the side effects of ACA, an unfortunate side effect is they got rid of the lifetime maximums, and you could see overnight that specialty drug pricing just went through the roof. That's one of the headwinds. FDA, as we've all seen of late, specifically with some of the advisors basically resigning based on the decision to move forward with the Alzheimer's drug. We've seen as of late the FDA come back and say, you know what, maybe we need to take a look at these oncology drugs that have been on the market for 5 to 10 years and aren't actually showing any value. The issue there is that it's an organization primarily funded by pharma, and they're approving drugs based on extraordinarily limited data, specifically in the specialty space. Physicians, this is one of those scenarios that we see time and time again. Physicians will absolutely want to do the right thing. And most of you large employers know that you're basically national sized companies where you can have employees across the country and you have a physician who's in a specific area trying to do the right thing, but may not understand or be at the cutting edge of what's happening in terms of the new drugs to market, which is a better alternative, et cetera. And lastly, PBMs. Now I can beat up on a PBM because I work for one, and I can tell you about about the issues that I saw both as a buyer and in my previous life on these, working for these cutting edge companies, PBMs, we just heard Antonio talk about it. Like, where is the financial alignment when they can push a drug through their owned pharmacies or specialty fulfillment and make a lot more money? That's number one. Now, the second thing is that if you think about in the last decade, primarily since 2012, we've spent a lot of time as a market pushing down traditional drugs, getting people to the generics, getting people to the lower costs in terms of what's 98%, 99% of what's being fulfilled. What the PBMs have done is they spent that time moving all of their, not all of their, but 60% of their margin into specialty. Why? It's because you have these 50, 100, 400, $4 million drugs that can be fulfilled and they can earn their margin there. So you're already in a scenario where the PBM is incentivized to fulfill the drug. They're not incentivized to control it, and they're going to make more money that way. So that's the headwinds. What did we do with these large employers? Next slide, please. Well, what we wanted to do is we wanted to set up the process for how we can affect a carve out. I'll wait on the next slide. Okay, so it's three things that we were thinking about. And again, this is me on the buying side for these large employers. So we needed to set the foundation. We needed 100% transparent and pass-through so that we knew exactly what the pricing was, we knew what we were getting. We needed drug level rebate reporting, and we wanted to control the benefit. Now that in itself was extraordinarily hard to do. That required significant leverage, RFP negotiations to get all of that sitting into one contract. And really that's just table stakes. That's just to get started. Behind the scenes, we knew that the eventuality was we were going to focus on specialty. Now that doesn't mean that we were going to carve out from PBMs that the jumbo employers that I had, the 4.5 million lives had. It just means that we were going to look for what's the best opportunity based on the data. But we were skeptical for all the reasons that Jonathan and Antonio were talking about. So we started with, let's take the data, let's take the control that we have, and let's start looking at incremental steps that the employers can make. And we used a lot of best practices that have come out of employers that are with the Midwest Business Bureau on Health. We started with, let's do direct to retail contracts and formulary management as a toe in the water to get our jumbo employers ready for what the big overall push was, which was a significant focus in specialty. And that's high cost case management, full carve out if it was something that should have been done, medical specialty carve out if that is the right solution, and an integrated approach across pharmacy and medical for the full specialty viewpoint. Next slide, please. So let's get into what some of these results actually looked like when we went down this path on behalf of these large employers. What you're going to see when the slide pops up, and it may be just delayed on my end, is that you're going to see basically three buckets. And the first bucket talks about, let's unbundle the conflict. Next slide. All right, I'm going to keep talking. Let's unbundle the conflict. There we go. So part of this is what Antonio was talking about. Let's eliminate the fact that the PBM owns fulfillment. So like other MBGH employers have done, we carved out retail. Now, what did that look like? It looked like a 2 to 12% savings opportunity with some significant disruption required. I mean, if you're going to kick out pharmacies, that means that a patient, your member has to go somewhere else. So I would say that there's great savings opportunity, but not without the downside of the effort that would be required. It all depends on what your what your current demographic of pharmacies that your members are going to. Likely it's 33% one big chain, 33% another big chain, and then the remainder is all the others. So you have to think long and hard about that. But it was a step in. The second one, don't chase rebates. Let's start looking at exclusions. Let's kick out the stupid drugs and focus on what's the lowest net cost. This is where you really have a good consulting partner and you're getting into eaches in terms of the formulary management. And we saw, just as one example, for one employer, as a large employer, jumbo employer, one contract edit was an $87 million return to them. And unfortunately, because of NDAs, I can't tell you what that was, but I would say that there's a ton of opportunity out there to really look at the formulary management. Dwight Davis talked about it this morning in terms of how his approach to formulary management. All of this, again, was the setup to get to specialty. Now, I have in this bucket here a couple of things to think about in terms of specialty carve out. We already covered that it's now the highest trend in healthcare. It's 1.5% of your patients or your members, and it's 40 to 50 to 60% of your spend. It's now becoming chronic use. It's covering new drugs to market. And in fact, if you look at the 7,000 drugs out there that are currently in the pipeline, 75% of them are specialty drugs. And we're all terrified about the $1 million plus drugs and how to manage them. This is the largest impact in the future. So what I did with those large employers is we ran a very, very long, it was an 18 plus month process of an RFI to an RFP, looking across the entire market at, can we buy direct from the drug manufacturers? Can we partner with health systems utilizing 340B? Can we aggregate health systems to use their purchasing power? Do we do the one-off copay assistance programs? Do we look at switching to another PBM? Do we look at just carving out fulfillment? Do we look at carving out the entire benefit? Do we look at doing it across medical and pharmacy? At the end of this long process, we chose Archimedes as the solution. And for a lot of reasons, and the primary reason is that their value was almost double everybody else's, but also because they offered all of the disparate points under one solution. And this is what the results look like if you go to the next slide. Now, as a setup to this last slide, keep in mind, we were doing this on behalf of jumbo employers, a lot of lives, which means our negotiated contract with the PBMs already in place was really, really good. I mean, we had tremendous discounts and rebates, but of course, the big news flash here is that that's not going to drive value. Next slide, please. So this is what the results look like. After moving from a big 3 PBM, moving specialty out to Archimedes across large sampling of large employers, we saw an average between 26 to 51% savings. In reality, it was more like 37 to 40% consistently, but we did have the outsiders that had the 51, and we only had one that was in the 26. The rest of the range was in the 30s and 40s. So what you're hearing is my goodness, that's moving from what we all come to believe is like you're moving from the big 3 to another entity. What about the rebates? What about the risk that's at stake? Yet they're driving a 26 to 51% savings. What's important is actually, and I can cover the rest of this, right? 40% of it was in clinical management, 60% in non-clinical. What's most important from my standpoint is that 46 to 53% prior authorization change rate. What that came down to was that was absolutely eliminating waste. That was the physician who was prescribing, he was prescribing growth hormone for children that were already at the 97th percentile in terms of height and weight. That was a change from a high cost drug with a 50% success rate to a lower cost drug with a greater than 80% success rate. That was a change of working directly with drug manufacturers to negotiate down based on cost per quality adjusted life year. So the net that I want to say with my piece on this is that I think Jonathan and Antonio pointed out a lot of the pitfalls that you'll find in these massive vertically integrated organizations where they own fulfillment and they own the conflict of if they fulfill an expensive drug, they get paid on it. You separate that out, you put yourself in a position where you can just carve out into your contract, they're going to fight you. Put that into your contract, you can use it as leverage. You're going to find a tremendous amount of opportunity. Thank you, Cheryl.
That was great, Tom. All 3 of you are rock stars, and I could listen to you all day. So we don't have a lot of time, and I love to call this rapid fire. So please limit your responses to maybe 30 to 60 seconds so we can get a handful of questions in. This is not an easy question. And I asked Dwight a couple tough ones this morning. He's like, I don't know, but he gave good answers. And I expect the same from you guys. But what is it going to take for the system to change, especially amongst the most egregious practices? Because we know that employers, we wish that employers as the real purchasers of healthcare and pharmacy benefits can make that change, but we keep having intermediaries and other players in the market preventing innovation and some of that change. Is it going to be driven by employers? Is it going to be driven by legislation? Is it going to be driven by disruptive lawsuits? Okay, so I'm going to start with you, Tom. What is it going to take to change? What are the top things that need to happen in 60 seconds?
Yeah, I would say that the first thing that needs to happen is a complete evaluation of how we buy drugs, to include looking at, and there are models already out there in the rest of the world of looking at quality adjusted life year metrics in terms of new drugs to market or just the current high spend drugs. You can have a country like Japan or Australia that they're just not going to cover certain high cost, low value drugs. And I think that we could do that a wholesale approach, and employers could do that as well. Number two, it behooves every employer to immediately go out and do an RFP on your medical plan and on your PBM and say the following: you won't make it to finalists unless you allow me to carve out, and watch them throw a fit and lose their mind because they put so much margin onto the disparate buckets of it. But you need to do it anyway as a negotiation tactic. I think that's going to move forward. I'm very skeptical about what the negotiations are going to look like in the future in terms of the overall value of the drugs and how you measure it, but that's a different question. So I'll yield.
Thank you. Thank you. Antonio?
Cheryl, the answer to your question is all of the above. It's going to take it all. The one thing that I would tag onto that is incredibly more amounts of transparency. We were only able to unlock the spread pricing problem in Ohio because we were able to squeeze knowledge out of publicly available data. And that publicly available data is very imperfect. I think we could do a lot more to create more data transparency, which is what unlocks a lot of the dysfunction that is embedded in the contracts in the first place.
Thank you. Jonathan?
Yes, so you mentioned the disruptive force of litigation, and I think that, and Antonio Chacha in his statements, he talked about dominoes falling. I cannot emphasize the enormity of Centene's $100 million resolution in Ohio, $55 million in Mississippi, and reserving $1.1 billion for other states. Centene is not the biggest player in the industry, and the type of litigation that's going to happen against these PBMs that are all doing the same thing is like the tobacco and asbestos litigations of decades past. And I'm not going to make a lot of friends with my next response. But I think that people in charge at self-funded plans that are in charge of benefits design have to really listen. And MBGH has done an absolutely amazing job. I have printed out everything that you've talked about. I mean, your organization is really, really on it. But the individual leaders at the self-funded plans need to have a better understanding of what is contained in their contracts. And I'm talking about, take a simple approach. Do you even have the ability to audit the PBM? What does your contract say about rebates? Do you get all the rebates? Can they hire a rebate aggregator, and so on? And so I think that there is a massive change happening in the industry, and I personally don't believe that a lot of legislation is needed. I think you have to negotiate better contracts.
I couldn't agree more with you. And I alluded earlier to the employer Rx evolution, which really was founded on what Caterpillar was doing and a number of groups that we're working with that optimizes your contract. That's the foundation and the beginning of everything. But you've got employers influenced by a lot of other players in the marketplace that say we can take care of that for you. I have to talk about briefly fiduciary. I've been talking about it for years, and literally 10 years ago, we were whispering it because we didn't want it to get out there. We didn't want, an employer or somebody to look at it. But if your if employers are almost always fiduciary, and it's really rare for them not to be fiduciary, right? It's a hard thing to do. Why aren't we doing more? And I think the first answer is most don't know how serious it is and the responsibility they have. Others that do have audit rights and have optimized their contract are a lot more comfortable. But any thoughts or comments on fiduciary and what employers need to be doing to ensure that they're covered? Very briefly, and I'm going to start with you, Jonathan, 30 seconds.
30 seconds.
To solve the problems of the world, right?
Absolutely. So a fiduciary means that your partner on the other side, for example, a PBM, is acting in your best interest, not theirs. If you take a look at some of your contracts, it's the PBM says, we are not acting as your fiduciary. We're acting in our own best interest. But as you mentioned, Cheryl, as under ERISA and many other state laws, employers are fiduciaries with respect to its agents, the employees. And so you really, in my opinion, self-funded plans have a duty to go audit and negotiate better contracts. Your employees are paying a copay based on the list price of a drug, not based on the other price. So I think that this fiduciary duty thing is important. That is where state legislation could happen. If state legislation would say PBMs are fiduciaries in our state, that would change things. The fiduciary issue cannot be overstated.
It would change everything. How about you, Antonio?
I'll just echo everything that Jonathan said. Completely agree. The lesson here is that PBMs are not looking out for your interests; they're looking out for theirs. That's not a problem. It's just something you have to recognize. And until they are forced to act in your interest, expect them not to.
Right. Tom?
Yeah, to the extent possible, until it becomes a reality about the fiduciary side for a PBM, I think some steps that you can do is demand for 100% pass-through, 100% transparency, have it fully auditable, and then separate out fulfillment from the actual management of it, because it is the fox guarding the hen house. It's not going to get you to full fiduciary, but what it's going to get you, it's going to eliminate as many conflicts of interest as you can.
I have questions about rebates that I can't get to. I have questions about what employers should do, but I think we covered some of that. My last question, and just a brief response, and maybe it's yes. I get relationships and how they work for employers and all the stakeholders and how people do business, but why aren't we doing more together? We all have such aligned interest. We all believe that, 10 to 40 and plus % increase in what you're paying than what you should is wrong. And this isn't just PBMs and intermediaries. This covers a lot of the different stakeholders in healthcare. So, we almost have to put it in silos to try and solve it. I always say to our sister coalitions, if we could agree on doing one thing, what's that one thing? And maybe it's, putting a stake in the ground and saying, we're not going to take this anymore. I won't swear because I always, have little more fun things to share. But do you think it makes sense for us to start collaborating in more meaningful ways to get that message out? Because you guys are on the front end of doing some of this.
Yeah,
right?
I mean, we've got to break down the silos, right? A lot of part of the reason we launched 46 Brook was to take the message to the public. There are many consulting firms out there that probably know more than I do, but they sell that information, okay? And I think that the consulting world, the broker world, and the employers and the provider community, to be frank, should all be huddling together and say, look, there's a massive gap between all of us. We need to eliminate that. So Cheryl, to the degree with which you want to play Twisted Sister, we're not going to take it. I am with you.
All right.
Cheryl, I'd throw in there that it is a fact that when I went out with over 2 million lives to do an RFP with multiple employers, I definitely made it a lot further than if I was doing it with a few. So it does require a large group. However, Amy Ball said it, and I'm going to reiterate what she said. There are mid-tier PBMs, and of course I can say this because I now work for one because they do such a good job. There are mid-tiers that are kicking the pants off of the big boys because they're getting to the lowest net cost through appropriate clinical usage, and they've unbundled the conflict. So you don't have to go that way. You can take a different approach, but I wholly agree that, and I'd love to see I'd love to see a bunch of employers come together out of this to move it forward.
You all got to comment on that last one, right? Okay, go ahead, Jonathan.
Super quick.
I couldn't remember if you had commented. Go ahead.
You asked why aren't people working together? I think that there's different stakeholders. There's manufacturers, there's wholesalers, there are plan sponsors, there's PBMs, and there's providers. Each one of them has their own challenges in working together. Sometimes it's antitrust laws. I know manufacturers, they're all giant companies, white shoe, and they're all afraid to work together for some of these issues we talked about.
Right.
Providers, there are clear antitrust rules that limit them. I think plans, I think there's a growing awareness with plans, and I think over the next year or two, organizations like yours are going to help bridge that gap.
Well, I appreciate that, and I don't want us to lose touch, and you know, I'm going to continue on my crusade soapbox, whatever you want to call it. I don't know if we're going to call it I don't think the top 10 commandments are the right terms, but some sort of a list of things that we're just not going to take it anymore. I think that was the Twisted Sister reference you made, right? So thank you for that inspiration, and I really can't thank you all enough. Hope you can hang around for the employer panel, and we'll talk to you soon. Thanks again.
Thank you.
All right, let's pull up our, thank you. Let's pull up our next panel, our final panel, and then please remember to stay a few minutes after this panel so that you can hear what we've been up to in terms of this whole area, as well as some new information. And there are the beautiful shining faces of 4 of MBGH's leading employers and board members. Very excited board members, 2 past chairs, all board members still. I'm going to start with Darren Hinderman, who joined Caterpillar's healthcare management team in the fall of 2004. His role as Six Sigma Black Belt and prescription drug manager has been involved in the active management of Caterpillar's prescription drug and healthcare benefits. He's been involved in the development of PBM transparency standards certified through the Human Resource Policy Association. And you did that a long time ago, and so glad that you got that started, because it used to be worse, right, Darren? Okay, Jason Perot is the Senior VP of Strategy, Innovation, Growth, and Partnerships for Vita Health. You may know of Jason, where he previously worked at Boeing, where he oversaw the healthcare strategic direction of the Chicago-based $94.6 billion aerospace company. He is a board member of the Employer Health Innovation Roundtable and the Pharmacy Benefit Management Institute, as well as MPGH with all of them. Sherry Samuels first is the VP of Total Rewards for Sargento Foods. She has held a variety of roles from HR to occupational health nurse to HR generalist. In addition, she serves to being on MBGH's board. She serves on the National Purchaser Leadership Council of the National Alliance of Healthcare Purchasing Coalitions. That's a mouthful, Sherry, and that is the umbrella organization for coalitions across the country that I'm on the board of. And finally, Tom Sondergeld, who is the Director of Digital Awareness for the Employee Health Innovation Roundtable, or the acronym is EHIR. He is a global executive, formerly in a leadership role in HR benefits from Walgreens. In his newer role at EHIR, he'll be curating a platform to aggregate digital solutions for employer members. He is also owner and senior consultant for TS Consulting Services, where he works with innovative startups, transparent PBMs, employer groups, and large employers in helping businesses offer improve offerings to their members and users. Welcome, you guys. It's so good to see you. Jason, I'm very excited. He's so sick of hearing me say this, that Jason can use he didn't have a camera on his last computer, and he finally has one, and he gets to use it. And I have to drag there's Sherry. I just wanted to make sure that Sherry was in there. I didn't see all of you. It's been a little chaotic, and we moved your panel up an hour. So I apologize, and I know a few of you might have some time conflicts. So I'm gonna start with the really big question that was when we did our prep call recently. We talked about something, and I want to make sure each of you have a chance to weigh in. There's especially a few of you who are experts in this. So I hope that I'm going to articulate this correctly. But I was surprised to learn, and a few of the other employers were, and we wanted to share it with today's audience, that there are groups out there like group purchasing organizations that are not very transparent. They could be hiding rebates. Certainly they're less transparent, and you can't audit them. Okay, and we're going to ask you guys to talk a little bit about who those organizations are. But there's also health purchasing alliances. I believe that's what the acronym means, and that are more transparent and auditable. And so because some of us were surprised to hear about these two entities, we knew about GPOs, but maybe not all of the hidden secrets, and we wanted you guys to talk about them. So I'm going to ask Jason and Tom to give your feedback, and then if you, Darren and Sherry, want to add any feedback, let's spend about 10 minutes talking about this, because I think it's really important. Even though it is pharmacy benefit specific, it does impact it, but this is bigger than big. So Jason, I'm going to start with you.
Sounds good. Thanks, Cheryl. Privilege to be here today. The bottom line is there are a ton of misaligned incentives, as we know. GPOs, rebate aggregators, great content that was addressed throughout the day today from brilliant leaders and speakers, touched on various components. And I would tell you, from an employer self-funded, self-insured side, over the last 3 to 4 years, I looked at everything from A to Z to try to figure out how we could create a new construct that would remove all the misaligned incentives. When John Levitt talked about audit rights, or what's in the contract as far as definitions, terms and conditions and restrictions and language, we just said enough's enough. I like the reference to Twisted Sister. We're not going to take it, because that's exactly what we were thinking, was we're going to establish our own construct, our own framework that is going to set the rules of the road for the PBMs. And ultimately, we're going to move forward with an RFP, invite a bunch of PBMs to play ball in the sandbox. But the key thing was they had to fundamentally agree without deviation to all of our established terms and conditions, all of our definitions. When we look at flexibility, when we look at control, when we look at auditability rights without restrictions, when we look at the definition of what is a rebate, that was all imperative to us, because we felt like it was ridiculous if we wanted to carve out specialty and give it to another entity. We're looking at a punitive PMPM fee that could be north of $10. It was cost prohibitive to do so. So there was a lot of language that just had to get changed. And for us as the fiduciary, we had to take back control. So what Demi McBride mentioned earlier this morning was spot on. And same thing with Darcy from State Farm. And I think what you'll see is that more and more employers that are self-funded are basically moving away from the traditional spread pricing models, because it doesn't make sense, as Ohio, it was a prime example, and move to an acquisition cost model. And when we think about the rights to audit any rebate aggregator or any GPO, we are setting the terms and conditions around that. If we don't, we're going to be perpetuating the status quo forever. What we did learn, though, through the RFP is there are PBMs, I'd say mature established PBMs, that do not want to deal with this type of construct. They do not want to bid on the business because it's going to be disruptive to their model and what they could potentially bring in terms of revenue for their shareholders. There's too much downside financial risk. That's the honest truth. So the reality is we learned a ton from the small, the mid-tier, and the large PBMs based on their appetite to play ball and what we were looking to do to, I would say, remove all these misaligned incentives, which was key. But the three quick things I would hit on is, number one, employers have the choice today. If you don't want to deal with the status quo, lack of transparency, constructs with the PBM, contracts that you have in place today, and not having full control, if you don't want that, you have a choice. You can easily make that pivot. And we've seen time and time again with support from Health Strategies and PSG and others really leading the way on that. So that's the number one thing, is actually committing to it, to take action and take back control. Number two, I would say, is finding a proven advisor or consultant that understands from A to Z what needs to get done. And there's a number that are really solid, and I would tell you there's a number that really are not. So run your due diligence to make sure that you're partnering with someone that's independent, objective, and not on the take from the PBMs from a financial standpoint as well. And number three, it's just a matter of demanding in that RFP, what is that sandbox of rules and definitions that you want? And then secondly, then move on to the financial phase and get all the pricing, but have the clarity, as we talked about earlier with AWP and NADAC and all the different pricing. You set the terms on what you want as an employer. And there's a very clear pathway, which I think will exceed every single employer's expectations with the outcomes and the results, that will far outweigh anything that you might have projected or modeled, because that's exactly what happened to us.
You're on mute, Cheryl.
I don't mean to put you on the spot, but any comments on GPOs versus HPAs? Because I'm going to ask that to Tom, and he's already been shaking his head.
GPOs are alive and well. Let's face it, it's not going to change anytime soon. So we've seen, you know, the advent of, I would say, the Ascents and the Zincs and others that are out there. They're not going away, whether we like it or not. I would say that there is an alternative when you think about HPA or other alternatives that can basically create their own employer-driven construct to basically take back that control and do what is in the best interest on the self-funded employer side. So I'll turn it over to Tom, but that's the short of it. You have a choice on that too.
Yeah, Tom, give us the dirt on the GPOs and the HPAs, because I had notes from our call and there was some dirt.
There is, and it's a murky solution, right? So GPOs, or group purchasing organizations, are typically done by healthcare entities, right? So hospitals do them, and now pharmacy benefit managers have started to do them. And what they do is they formulate an organization that's separate from themselves, but run by them, that buys en masse on behalf of the PBM, right? So group purchasing organizations are of the PBM. So Ascent and all those other ones that are out there, there's like 7 of them, they are all built by the PBM. And they then get to follow all the Federal Trade Communication rules and regulations around group purchasing organizations, which make them unauditable. You cannot audit a group purchasing organization. And because you can't, they're able to do a lot of stuff. Now, they will come to the table and tell you that they will save you money. They will, because a group purchasing organization by definition is going to save money. But what they're then doing is they're keeping a bigger part of the spread and a bigger part of the rebates that are now coming through the GPO as part of their margin or their revenue, right? And then that gets passed back to the PBM. So you as a buyer feel like you're getting a good discount, where the discount could be 15%, you're getting 5%. Oh, that's a pretty good win in a pharmacy benefit plan. That's $100 million, right? No, because in transparency rules, you're not getting it all. So it's a really wicky system, and you have to be very careful, and you have to ask the right questions about what's going to happen if you're going to buy from a group purchasing organization. Now, you can get savings, and if you don't want to get 100% of your transparent benefit, then it's a great solution. Health purchasing alliances are typically formed by the buyer. So the employer joins a health purchasing alliance, and they buy together the medications or the health solutions for that group. They're auditable because the group defines the rules. All the money and savings pass back to the group members. They're not saved by anybody else. These are not run by the PBMs. They can't be. PBM can partner. They can certainly join a health purchasing alliance, but they're not running it. It's run by the employer. Maybe the manufacturers are involved because they're the ones that are passing on the discounts, right? And so in these two solutions, you just get variability. Now, most PBM contracts today allow the employer to carve out portions of their pharmacy to other solutions, and you can carve it out to a PBA or an HPA. And so an HPA could actually run a lot of your pharmacy benefit through your PBM, right? And so check your contract, make sure you look at it, make sure you understand whether or not that's possible. But there are HPAs that are coming up to answer the GPO problem that exists in the market today, because GPOs are taking a bigger and bigger piece of the pie.
What are, I thought GPOs also included the pharmacy benefits offered by the consulting houses. Are those GPOs as well with the same types of rules?
Well, consulting houses have a harder time creating a GPO on their own. I suppose they could, they're probably more likely to create or participate in an HPA than they
more
are
like an HPA. Okay.
more like an HPA. Now consultant houses are creating their own pharmacy consulting benefit solutions by partnering with the PBMs and bringing savings to the table in a consortium model, but they're
They call
not
them coalitions. They call them pharmacy
coalitions or
coalitions. So is
Yeah,
that
yeah.
okay?
Different model.
They're more transparent, or they're not transparent.
They can be more transparent because the consultant's going to manage that contract. But what's not transparent is how much the consultant's getting from that piece, right? So they get a piece of the pie. Everybody takes a piece of the pie when they jump in the game.
Yeah.
And so when a consultant sets up a coalition, they're setting it up for a reason,
Right.
because they're going to bring savings. But again, if you could get 10% savings and they're going to keep 2, you're only going to get 8.
Right.
So are you
Jason,
really
did
getting
you
all
have
your
another-
savings?
Go ahead, Tom.
All right,
Finish.
go ahead. Nope.
Jason, did you have something else to say?
I'm good. You can keep it going.
It's fabulous to see you on camera. Darren, any comments or thoughts on this before I go to Sherry and we go to the next question?
No, I think just part of our discussion a couple weeks ago raised the issue to me for the first time. I was unaware of GPOs. You know, my first reaction was, it's awesome if you can add a middleman to a middleman. I mean, how great is that? You know, that's like an ideal situation for a PBM. PBMs, after reading about them, my feeling was that we were starting to make inroads and they got scared, right? I mean, they became more and more companies were getting audit rights, and more companies were demanding transparency, and more companies were moving away from spread pricing and demanding 100% pass-through rebates. So what do? I figure out another way to hide my revenue streams, right? And that's what I feel like is happening with these GPOs, is that the PBMs have discovered a way that's not even based in the United States and unauditable to move money around based on how they purchase drugs. And so from my perspective, it creates one more reason, you know, to move away from traditional models and even traditional PBMs that especially participate in these types of arrangements.
I have a great knock-knock joke. Knock, knock.
Who's there?
What's the difference between a middleman and a middleman of a middleman? A ghost.
That's going in the notes, just so you know.
It's a hider. It's a hider. Believe me,
pretty
it's
good.
a hider.
Sherry, how about you? Any comments or?
Well, actually, in this space, I didn't know it, but because I'm not as sophisticated as these guys in this space. We belong to an HPA coalition here in Milwaukee, and we're with the full transparent. And we do, after we had our discussion a few weeks ago, I double checked, and yes, we have audit rights. And the only reason we had joined the HPA was actually to reduce the administrative fee, because that's all we pay with our PBM is an administrative fee. And there was a no-brainer. We were staying with the same PBM, same pass-through, fully transparent PBM, and we joined them for that reason. So
you're already benefiting from that as a smaller to really a mid-size employer. I know Jason's got to leave us in a couple minutes, so I'm going to jump forward and then come back to the other three of you. Our program today, and you all have been on employer advisory boards that I've run, where I've been talking and, you know, with my little crusade and soapbox about how the heck are we going to, actually I say HE double hockey sticks. So I did swear once today, but how the heck are we going to pay for these high cost gene therapies? And then you've got intermediaries adding to the cost of them. And as you know, we talked about, you know, the two solutions that the vendors and health plans or PBMs are looking at that just shift cost versus performance-based guarantees versus outcomes-based guarantees. And then, of course, one thing we didn't talk about because we always knew it was out there, which is stop loss, which they're not going to cover. They've already kind of said that, the stop loss carriers, but any comments on that, Jason, and where we need to go to reduce the waste and the egregious practices so that we can offer best price for these really, really high cost gene therapies?
Yeah, there's no answer today. From my opinion, we have employers that are self-insured, self-funded that are covering these products, these high-cost gene therapies and high-cost specialty products. And And they're basically invested in phase 4, which is the real world evidence. We're hopeful that we see long-term durability and efficacy out of this, but who knows? Who knows if this is going to hold up 5-10 years from now? Time will tell, right? What we do know is in 2015, based on a study, that 2/3 of all cancer drugs that were FDA approved between 2008 and 2012 simply have no evidence to prove that they work. So there you go. But it all goes into the RWE. And I'm hopeful and I'm optimistic that, these are just, very promising, high cost gene therapies and cell and gene therapy products that can be life-changing and altering. And, at Boeing, we were covering all of them since day one. But I'll tell you what, there's others that are not. And there's others that are large jumbo employers that are not. And there's small, mid-tier that simply can't afford it. So what we have is two classes of haves and have-nots. And some of the have-nots are doing it out of choice because they don't think it makes sense yet. Because A, it's not price effective. And secondly, they don't have the data and evidence to show that it's going to, be effective when we think about long-term. Is this really going to be a one and done, or is it going to have to be re-administered or something else, done at some point in time, 5-10 years out? Who knows? And how do we fund it?
That's where curative comes in. I'm sorry, Jason, what?
Yeah, no, it's exactly, how do we even fund it too, right? So it's a tough one.
So we're looking at, it comes down to efficacy. Is it going to cure that person? And then maybe, we can sort of justify that amount. And certainly more transparency with the pharmaceutical and biopharma community in proving the value and starting to look at outcomes-based guarantees in the future. Darren, thoughts on this topic?
Yeah, plus I have a title for your, next year's program. We can just call this Employers Scared Straight, because everything today has pretty much scared it made my hair curl. And there are, I think employers are going to get a wake-up call, as Jason said, because over the past 10 years, we've funded the move in specialty pharmacy through the erosion of brands on the traditional benefit side. So we've not seen a significant move in our pharmacy spend. Nobody has, as they're going to see in the next 10 years, because our general traditional pharmacy spend has gone from 40% generic utilization to 90%. Okay, everybody's has, essential. So with the cost savings of that, we funneled almost all of that cost savings into the specialty products that have come about since then. That's over. We no longer are going to be able to pull from that piggy bank. So what's going to happen from here on out is these specialty drugs that are launched and the new ones that are coming, as we've seen in the pipelines, are going to be direct impacts to our budgets. And we're going to have to start, as companies, justifying the cost of these to our CFOs. Where before we could kind of hide them, behind the scenes a little bit because we were getting so much cost savings on the traditional pill side. So having said that, as these new therapies come out, I think we have to, as Jason said, put a stricter limit on, from a clinical efficacy perspective, are they the right thing for a certain disease state? So the new drug that's coming out from Biogen, everybody I'm sure has heard about the Alzheimer's medication that's coming out, that, the advisory panel for the FDA said there's not enough evidence to support the launch of it, and the FDA launched it anyway. Right. There's recently a study that's come out that said for Medicare patients, if this drug is launched, the government will spend more on this than the NASA budget. It's somewhere between $9 billion and $26 billion a year for this drug through the Medicare budget. How are we going to pay for that? We're going to have to use stringent clinical criteria for these medications that come out, and only the people that strictly qualify for them. And then you hope they work. That's where we're at right now as employers. But clinical criteria are going to be key. And if you allow the PBMs to drive the clinical criteria, for damn sure people are going to, I think I just cussed, I'm sorry, Cheryl. For darn sure, they're going to get approved, right? Because that's in their financial best interest. So employers taking over the clinical data, the clinical criteria, and the clinical decision-making, I think it's going to be even more pronounced in the coming years to help modify or limit the people that get these medications, that make sure that they're appropriate.
Sherry, how about you?
And for small to mid-size employers, which a lot of us are, we don't have the expertise or resources to take over that clinical data. So we're going to have to lean into our consultants or brokers and make sure it's not the fox watching the hen house, even though we're in a fully transparent model, for instance, and we have been since 2010, we've always had a PBM consultant. We actually had PSG in 2008, believe it or not. And our broker consultant pharmacy benefits expert actually works in concert with myself, our medical director at our on-site health and wellness center as necessary, and our PBM pharmacy, because they have a P&T obviously to review things. And we just work collaboratively on things just because we don't have that manpower internally to do it ourselves. But I agree with you, Darren. It's clearly that's the direction we need to go, and we need to get, as one of the speakers earlier said, get to it before the horse is out of the barn. Or
yeah, and I would add to you, Sherry. I mean, it's
bad employer that doesn't cover it, and you know, with the talent war going on right now, that gets out on, especially in small communities, it's going to get out on the street, and they're going to, you know, hot potato. You're not going to be an employer of choice any longer.
Yeah, and I'll throw a plug in here for what Cheryl said earlier too, is the fact that we have a solution for small and mid-sized employers, and it's through Rx Evolution.
Through MBGH.
Through
yeah.
MBGH.
Yeah.
The clinical backbone's already built. It's there.
Yeah.
You know, everything is there. The cost plus pricing models, the formulary management, the clinical decision making, all of it is built for. Cheryl built it all for you. So mid and small size employers can take advantage of this through Cheryl's program. And you talked about people banding together. Cheryl, it's an awesome opportunity for small and mid-sized employers to band and come into one solution and have the clinical backbone that we have, that every large employer has.
Right.
So.
And you guys were, you know, the founders, one of the many handful, really the founders of the optimized contract and doing things differently. And now we're seeing everybody doing it, not everybody, but a lot more organizations. And I'm going to come to you, Tom, in a second, but I encourage everybody on the call today to go back at that earlier slide when you can see that not all employers feel the same way. There were employers in those quotes that I shared this morning that talked about, we don't want to play God. Or if we can afford it, and you know, our bottom line, if it doesn't put us in the red, we'll pay for it. But then you've got employers that are saying no. They're singing Twisted Sister is what they're doing. Tom, how about you?
Yeah, so you know, boy, the whole space just needs to kind of have a refocus. I think there's so much concentration on transparency when transparency hasn't been defined, right? And I think that's a tough world. We've all kind of bought into the belief that transparency is something that's just going to exist, when every time we try to uncover the next new leaf of transparency, there's a creation of something new that hides more transparency, right? Because the middleman exists to be the middleman, and the middleman in a democratic economy takes money. And as long as you have that structure, and until you get somebody who really can, and there are a few out there that just charge a price for processing claims, then you've got to get everything else out of the way. And I think the whole market is fraught for fixing it. But I think we're going to find that the next year is going to be really tough for people. I think coming out of COVID is going to bring a lot of surprises to cost in medical plans and in pharmacy benefits, where people kind of didn't receive care are now going to get care back. And I think we've all thought we've started to see that, and we haven't. I think we're going to see it en masse in 2023, and it's going to be a shocking year. And I think we should be prepared for that. And in that's going to come our need to address cost pressures all over the place again. And I think pharmacy is still one place where it exists, and we've got to look for it, and we've got to be smart at trying to uncover all the places it exists.
And I'm going to share something that I don't talk a lot about in larger groups. It's not secret sauce or anything, and I'm not asking you, any of you, to comment unless you want to, but we've seen not only with ourselves, but some of our sister coalitions, that we've never had PBM members because they know how disruptive we are, or at least the major ones, I should say. We have PBM members, but it's the ones that are transparent that are trying to do the right thing. But we've seen an exodus of even the big health plans from coalitions, because the big guys, the M&A activity, they recognize that they don't want to make less money. They don't want to unbundle what they've created. And, I think about when the ACA was passed 10, 12 years ago, and now with COVID, those were opportunities for them to look at what they were doing and preserve revenue by pushing the balloon in a different direction. I'll give you this, but I'm going to take away this. So it makes us sad that those collaborative opportunities for real change, they're hunkering down. And I'm not asking for any of you to say anything unless you choose to, but that's what we're experiencing and it concerns us. So I'm going to ask you the same question, or a similar question that I asked the last panel. Should we be focusing on legislation, or on employers pushing the envelope, or on disruptive lawsuits? And we heard their answers, and I think in general they were kind of in alignment, but what are your thoughts for that? Tom, I'm going to start with you.
Yeah, I mean, the landscape in DC is such a mess. I mean, we can't even get crucial things passed, so I don't know that legislation is going to be the thing. Regulation takes a long time in this government. I don't know that employers should look to the government to make this fixed for them. Plus, the government initially focuses on government programs, so Medicare and Medicaid, and then we follow usually, or the laws get extrapolated onto us and the regulations get extrapolated onto self-insured plans. That takes way too long. I think employers need to be the voice, and I think we need to be demanding. We're self-insured, like you had conversations in the past couple of hours. It is our fiduciary responsibility who sit in the chair to manage our plans on behalf of our members. You cannot pass that fiduciary responsibility to somebody else. Ask any ERISA attorney. You can't. I don't care if you write it into a contract. By law, you cannot give up your fiduciary responsibility. You have it as a self-insured employer. And if that's the case, then we as a self-insured employer have not the right, we have the duty to pretend that our members are us and treat them as if they were our mother. And how would you want hopefully you like your mother. If you're gonna make your mother pay for a prescription, you want it to be fair, and you want her to have everything she should have. And as an employer, I should fight for that in every contract, in every negotiation that I have. And that is my right and duty to do so. And I think we're sometimes still too timid to do that, and we shouldn't be timid. We should be demanding, we should be forceful, we should be creative, and we should be innovative. And that's our duty and responsibility. And I think it's going to come from that. I think we've seen more move from self-insured employer involvement than we have from any regulatory involvement, except for ACA, right?
Sherry, how about you?
Yeah, I agree with you, Tom. I also do know that the contract is just one part. The drug manufacturers pricing, sometimes we've got one drug on our plan right now that's $350,000 a year for one person for a $2 million spend. Well, that's a significant, 16, 17% for one individual, and it's a genetic thing that's ongoing. So working through how do we make sure that the drug manufacturers themselves are making, a fair profit. Everybody's in business to make a fair profit, but that the patient also gets the care that they need as well. So is there a way for us to do things through a 340B? It's kind of like the copay accumulator type things, or the copay assistance stuff is for rare and genetic diseases, especially for, I hate to say it, but smaller mid-sized companies that can't afford it. Is there any state assistance? Is there any opportunity for us to do anything like that? And we have done direct contracting for 340B, for instance, through hemophilia treatment centers, specifically for that case. This case that I have now is not a hemophilia factor issue. And it's working together with the health plan, the PBM, if we can have the health plan case manager work with the family and of course through HIPAA, allow us to, work together, that we gotta solve those problems, because ultimately we're not going to be able to afford healthcare for all of our family members, our 3,500 belly buttons on the plan, because of one person or a small percentage of those claims coming up. And it's not something that we're going to be able to turn away and say, we're not going to cover it in this case. So I think that it's multifaceted. I don't know as though legislative, Tom, I 100% agree with you. The gridlock in Washington is insurmountable for a lot of things. So how do we get, upstream and downstream together, and working together is one thing, but then also working one off and making sure that we do direct contracting where we can for these rare and genetic diseases, and having some plan language built around that, which we have put into our plan specifically for rare and genetic diseases. If there are these centers of excellence in this, the hemophilia treatment centers is one example of them, but you can look broader for that type of a thing. That may help mitigate some of the costs and get you the best pricing available as well.
Darren, how about you? And then I have a couple of questions from the audience.
Yeah, I mean, here's where my passion lies, Cheryl, and I feel like we as employers have brought this a little bit on ourselves. I mean, there's been forums to cooperate over the years. You mentioned that I helped with the transparency standards. We did that in 2005. Tom said there's no defined transparency standards. There were in 2005. We defined 9 of them, that if you met these, and we put them all out there, and we had certified PBMs that say, yes, if we have an employer that comes to us and wants these transparency standards, we will adjudicate those for this administrative fee. We did all that. And you know what happened is the PBM said, well, you can take that, or you can take this non-transparent deal for a little bit less money. And they're like, well, we'll take a little bit less money. And so we've done these things over the years. I mean, the employer groups have been out there. The opportunity to disintermediate the PBM model are there. We've been talking about this for years. It's that employers have still just not felt the need or the want to go down many of these roads because it's too hard. I don't have the staff. We hear all the excuses. Right. We put it into the the MBGH model. You can just go hire this all and be done, and get all your cost savings. And you get collective eye rolls, or oh my God, that's hard. A lot of this the employers have brought on themselves, and it's going to take based on the last panel, a lawsuit as your fiduciary responsibility into these plans to really wake us up. But the opportunities are there to save money. The opportunities are there to adjudicate a better plan, the sustainability of the plan, affordability to your members. There's so many opportunities to take advantage of in the industry today that weren't there before. It's up to the employers now to do that, because that's what changes the industry.
And I think it's important to note that the program we offer is agnostic to what PBM you use, right. In that if the PBM that you use doesn't agree to what you want to do, you need to walk away from them. That's not rocket science, because we're going to find a PBM that will, and you're not alone in that process. So I have 3 questions. I'm going to ask you to limit your answers to a minute each, because I have one rapid fire round. Last question. So do you believe that when PBMs are saying they provide pass-through retail pricing, that they are passing through rates from a different contract with retail pharmacies, one that refers to pass-through, but for employers? So it's still not the amount being paid to the pharmacy. And Darren, you're shaking your head. So you want to answer that?
No, but yes, of course.
Well, you shook your head, so.
They have multiple contracts, and yeah, they go through multiple channels. That's correct. They have an employer-only pricing schedule. Of course they do. So
every single contract is different for every single vendor, for every single situation, for every single, right?
That's correct. That's correct. Yes, they can create that, and it's in their financial best interest to do so.
Tom?
Mute. I agree with Darren. I'm not going to expound on that answer any further. I agree with Darren. I think it's yeah. I'll let Sherry chime in.
any
I've talked
additional-
enough.
Okay, no, it's
well,
fine.
we were with before we changed to our current pass-through in 2010. We were with one of the large three, and I had actually done some analysis at that time with my assistant, and because we were looking at something, and we termed it the fleecing of America.
There you go.
Because they were upcharging for even for generic things, and we're like, what? And so
There you go.
no longer with them, and we are with our 100% pass through. And I was specifically told, well, you're going to UHC, why wouldn't you use Optum?
Right, right.
And you're going to get a better.
Let me count the ways.
No, no, I'm not changing. And that was in 19. 9 years after we had already switched, and we have this. I look at them as a great partner. So I just yeah, we've experienced it before, and maybe this is one of the benefits of being in the mid-sized space, is that we have this capability and this in our backyard. Matter of fact, they were Appleton, Madison-based companies, so it works.
Well, it leads to the next question, and if you want to share names, you can, but you don't have to, and it can just be a yes or a no, and I think we all know the answer. Are there PBMs that are receptive to all the things we're talking about today? And would we collectively agree yes?
Yeah,
and
there are some
smaller to mid-size, fully transparent PBMs, and and I remember 6, 7, 8 years ago, it started out small. You had 1 or 2 or 3 or whatever, and it's just dramatically increased. And whoever asks that question, if you need names, let us know. But my other question is it's difficult to determine who, in capital letters, who determines what exactly is a fair profit. And I think that that's on the pharma side and on the PBM side. So for pharma, how they're determining how much they should make, and at what point does that stop, if it ever stops. So right now it never stops. And then for pharma, what is a fair profit on the drug side? And so Tom, I'll start with you.
Yeah, I mean, I think profit is such a wiki term. I think the difficulty with profit is that it's defined by the company that's producing the profit, that needs the profit, that has the margin to achieve, that has the revenue to achieve for their shareholders or their leadership, right? And so I don't know. Profit's a misnomer because a PBM has a need to establish a profit. The problem is the way they get to it, right? If they would just say, we're going to charge this fair fee, and that's all we're going to charge you, like a transparent PBM does, and everything else is 100% pass through, instead of trying to keep a piece here and keep a piece here and widen the spread on AWP and create a MAC pricing list so they can keep more, create a GPO and share some of the profits, do something with rebates. We all know they keep between 4 to 8% of the rebates now. So how's that transparent? Well, it's transparent because they tell you that they're keeping some of the rebates. That's not fair. And technically, the rebates belong to the plan. They don't belong to the middleman. And so I don't know. Profit is a misnomer. I think they have to be they need to be transparent on what their margins are and what their operating costs are, and then I can help them determine what their price should be as the self-insured employer, and that's all there should be. And that's what it should be, and it should change based on the size of the employer. Because I'll tell you that if I'm paying PMPM with 100,000 lives, Sherry shouldn't have to pay the same PMPM for 10,000 lives, right? And so the world needs to kind of open up their doors a little bit more, and I think that's the biggest problem.
Hasn't answered that. I think it's Sherry and Darren. Sherry?
Yeah, obviously, Econ 101, supply and demand is going to determine profits and what they can charge if they can get away with it. Just like the hotel with Trivago, you got 10 of them, you got different prices. The customer is willing to pay it. It's just what they're going to get, right? And we're in that full pass through. So I go up the chain and go to the more of the drug manufacturers and what's a profit, what's a reasonable profit. I suppose I could ask my sister, who's a patent attorney at Pfizer. And she might have a different answer for me. But therein lies I think the bigger challenge is with some of these cell and gene therapy and what those costs. I mean, what we pay to our PBM and the rebates, as much as that's inciting us right here and now, is nothing compared to what some of these cell and gene therapies are going to cost us in the future, and how do we mitigate those costs? I think that's we're going to cut off our nose to spite our face to do an admin fee or a rebate amount, when really the true cost is, upstream a lot further. So, and I'm not sure how to get to, I'm not suggesting I know how to get to that cost. I'm just saying that we have to be careful. It's like that balloon theory where you push in one side, it's going to come out the other, and we're going to be careful for what we ask for, right?
Yeah. Darren?
Yeah, I hearken back, when you talk about profit, I hearken back to what Alex, your friend, used to present. And, profit margins of pharma companies are between 9 and 10%. Profit margins for pharmacies themselves that dispense the drug are less than that, maybe in the 3 to 5% range. Profit margins for PBMs are in the 30 to 38% range. So, the margins themselves are a lot higher.
That's the average, Darren, right? That's the
right.
average.
Yeah. So if you're just looking at that, the people that are making the most profit, even though but not by numbers, but by margins, is the PBM industry, and they're just the middleman. They're not delivering. They do not provide any value into the system. The value is the creators of the medications, people that move them, the wholesalers, and the people that dispense them and get them to our people, which are the pharmacies themselves. Everything else is behind the scenes in adjudication and, making sure that your insurance works correctly. And, where you place the value is not where the profit margins are following. And that's why more should be probably exposed in the PBM side to understand what the profit margins should be and how we should reimburse them. But still to this day, their profit margins are in the high 30% range. And I just don't know that they add enough value into the supply chain to warrant that.
Well, it's interesting that, most employers don't know that there are other options, right? Those of us that do often, have internal politics that they have to stay with one group or whatever the case is. We've been talking as part of this group for 8+ years about direct contracting with manufacturers. I think these high cost gene therapies this is an environment where it makes sense for us to consider doing this. And we all know that when we re-up our business or we go out to bid, that's the opportunity to have that ability to say, I can do whatever I want. Others have talked about it that are part of, our group that have said it's in my contract now that I can do direct contracting. Will the pharma do it? They're still scared, because of the threats by PBMs. But if you've got these really high cost gene therapies, there may be examples where that's a way we can dip our toe in that water. Any comments on that, Darren?
Yeah, sure. I just have one. We talked about direct contracting with manufacturers, but, we could do cost plus pricing and direct contracting with our pharmacy partners already and move away from the AWP model. I think that's at least a good first step. When you talk about direct contracting with manufacturers, that's what I will say is hard. We've gone down those avenues with some manufacturers. First of all, just for one drug, they won't do it. They need a portfolio of products if you're going to do direct contracting. And if you do that, you might be adding drugs to your formulary that you really don't want.
Right.
But you're going to have to add their whole portfolio to, direct contract with one of their drugs. So to me, going directly to the pharmacy partners and, setting up cost plus models on acquisition cost plus is a great solution. It moves you out of the AWP model. Right. It really gets you back to what they're paying for the drug and giving them a fair profit. We talked about profit. And that's already built. And, through Rx Evolution, you can take advantage of cost plus for pricing and move away from AWP. That's where I would start. If you want to get into direct contracting down the road, maybe, but that's where I would start with it if I was an employer.
It's a really good point. I'm just trying to pull the high cost therapies back in, but you're absolutely right. Sherry, how about you? Any additional thoughts on that? Okay, Tom?
No, not really. Darren covered
Well,
it.
you guys
pretty
are
good.
awesome. I feel like we should get a glass of wine, but it's a little too early for me, or I'll be in bed at 8 o'clock. This was excellent, and I want to thank you so much for committing your time to share your thoughts and views and perspectives. And I would, I'll see all of you hopefully soon. I would like Lori to bring up our slide for Judy Hearn, who's now going to share just about 5-10 minutes with us on some research that we've been doing on the cost of insulin and if legislation has had an impact on that. And then we'll go to Denise Giambalvo, and then I'll wrap things up shortly. So Judy, are you with us?
I am with you.
Thank you.
So the average price of insulin has skyrocketed in recent years, tripling between 2002 and 2013, and then doubling between 2012 and 2016. And this basically made this essential medicine unaffordable for many. This can greatly impact the person with diabetes, their health and well-being, whether they have type 1 diabetes or if they have type 2 diabetes requiring insulin. So this can cause them significant anxiety and stress. Research has actually found that the practice of insulin rationing, which is taking smaller doses or even skipping a dose altogether, is becoming more and more common than our health system would really like to admit. So across the country, state legislatures reacted by setting maximums on monthly insulin copays. They were looking to resolve the affordability issue facing many of those who require the insulin every day. At least 16 states at this time have enacted limits on insulin copays. The Illinois legislation was effective January 1 of 2021, and their maximum copay is $100 a month. I don't know about you, but I'm not so sure that's affordable. An interesting comparison is that Medicare, with their Part D plans, have set a $35 maximum copay per month on those that are covered by Medicare Part D. So we need to ask a question here before we go on further, is what populations are taking advantage of these lower copays from state legislation? And for the vast majority of them, the state legislation only covers those plans that are fully insured through the state, or they may cover state Medicaid plans. Well, we're like, okay, what about the uninsured? And what about all those employers, like most of you on the phone, on the Zoom, who have self-insured plans? Well, as you probably already know, ERISA has an exemption for self-insured plans, so you are not subject to state legislation and the mandates they may put in place. And unfortunately, anyone who is not covered by insurance, they don't take any advantage of the state legislation because they're not under a state mandated plan. So that's a big miss. So what can you do as a self-insured employer about insulin affordability for your covered population? First, if you offer a high deductible health plan, there are options on how to treat coverage for insulin. In July 2019, the federal government updated guidelines for high deductible health plans to include the addition of insulin and other glucose lowering agents, to add them to the preventive drug list with high deductible health plans, which then allows coverage for those medications before reaching that deductible. Guess what? My high deductible health plan is $2,800 as an individual. So you can just imagine the impact of having to reach that before you're able to take advantage of your drugs on a monthly basis with lower copays. So the MBGH employers that I've spoken with on this topic have relayed to me that state legislation has not impacted their decisions on pharmacy benefits in general and making insulin more affordable. So many of you already have drug copay maximums as part of your regular drug benefits. Make sure that insulin is among them. There are multiple forms of insulin, and many of the PBM formularies restrict which insulin is available to your covered population. So for the person with diabetes requiring insulin, having to change from one insulin to another because their plan's formulary changes year over year, that can really wreak havoc on the health of them. So whenever possible, offer all of those on your formulary to help those people. Diabetes is probably one of the most costliest diseases affecting your population. So keeping individuals compliant with their insulin and other medications is really critically important, not only to their health, but the health of your bottom line. So as a recap, here are some action steps for self-insured employers. We're going to be coming out with a report very shortly that includes all this information for you. So Centers for Medicare and Medicaid Services, their guidance is cap insulin copays at $35 for a range of access, and that was following their May 2020 executive order. You can follow this action and limit copays. So consider under your plan design strategies, formulary, ensure all insulins are on the formulary. Review your formulary for insulin placement. Understand where it is and what the costs are. For cost sharing, place insulin in the lowest price tier possible. Reduce the copay or reduce the coinsurance. And you may consider allowing the use of copay cards. For value-based design strategies for out-of-pocket costs, if you add a care model for achieving lower HbA1c, you can either lower the cost share for those compliant individuals or remove the cost share. And many times these care models can allow engaged members with diabetes to receive their insulin at reduced costs or for free. We've heard this a couple times already today. Contract reviews with your PBM and your medical carriers are really essential. Do these annually. And also for your performance guarantees for both, make sure that you're doing a true up at the end of the year and that you're auditing them. So a few other things. If you want to engage in a conversation with me and other employers about stemming your covered population from going from pre-diabetes to full-fledged diabetes, watch for information about an executive briefing that I'm helping put on that will be on July 14th. Information will come out and be available to you very soon. And also remember to check out MBGH's Diabetes Management in the Workplace Toolkit for information and resources on how to structure your programs and provide lots of information. You'll find that on our website at mbgh.org/diabetes. And thanks so much for your attention. Back to you, Cheryl.
Great, Judy. Thank you so much. I love that we're able to share that information with our members with guidelines, and that report will be coming out in the next month or so. So take a look at that as well. And let me invite Denise Giambalvo back up, and she's going to share a little bit with you more about Midwest Health Purchasers Collaborative, which is our purchasing group for our smaller to mid-sized employers. Welcome back, Denise.
Thank you. Thanks, Cheryl. Good to be back with all of you. As Cheryl said, I'm here to talk about our Midwest Health Purchasers Collaborative. If we could go to the next slide. So these are our trusted partners. There's been many references to these today, and so I'm pleased to have this opportunity to tell you a bit more about them. Carum Health, Day 2, Ebrx Results, Health Strategy, Inspira Health, and Shortlister. Next slide. All of these have been fully vetted through an employer advisory board of ours, and they're all available to you at a reduced rate as an MBGH member. Next slide, please. There we go. So Carum Health, this is results from a study that RAND did. On Carum Health's data, I believe they had 8 employers who submitted their data for this research. And what came out is they avoided 30% of unnecessary surgeries, or 30% of unnecessary surgeries were avoided. There was an 80% reduction in complications and readmissions. They drove the proven savings through ROI for their mature clients, and had greater than 45% savings per procedure versus market. So this is a Centers of Excellence platform that they have. The surgeries that were in these claims were for spinal fusion, total joint placement, and bariatric weight loss surgery. And the experience that people had was a net promoter score of 96, and 90% of them engaged on the mobile app. Chris Whaley, Dr. Chris Whaley from RAND, who led this research, I'd like to quote him on this because I think he says it all. With our analysis of Carum Health's market-leading COE platform shows that both employers and patients can see immediate and significant savings on completed surgeries while getting high-quality care from the top hospitals around the country. This is a perfect example of where there's money being left on the table. It doesn't take much for employers to put this in place. And if you want to learn more about it, just contact me, and I'm happy to connect you with Carum. Let's go to the next slide. Day 2, they do diabetes management. They have precision nutrition in place, and this is 1-year outcome from their program. So a drop in the A1C, so 1.0 or more drop in A1C. Increase in energy was 64%. Time in range for A1C increased by 69%. They saw a decrease in weight loss of 11 pounds. Sleep quality improved. Hunger was reduced. Stress, net promotion score was 87. 88% were engaged. And there was a 34% decrease in medication. So they are moving members with diabetes, type 2 diabetes, into remission. They're having great success. We are having a kind of fireside chat with them on July 13th. So if you're interested in learning more, watch for that in our newsletter for you to register. Next slide. Inspira Health. Inspira works with people who have multiple chronic conditions. They are also getting fabulous outcomes. Again, these are our preferred partners. There's a reason why we chose them as our preferred partners, and it's because the great outcomes that they're getting. So A1C, a drop in that, so 14% for members with baseline A1C above 7.0 saw a 14% saw a drop. BMI, 9% decrease in BMI. The baseline was greater than 30. Blood pressure, decrease there. Their glucose, LDL, mental health, great improvement. They, because it's a whole health approach that they have. So we love seeing that with the mental health going up 43%, 82% of care gaps went up. So the average baseline of 3.3 open care gaps. So they improved that by 82%. Net promoter score at 94, and 84% were still engaged after 12 months, which is excellent. And they recommend really 12 to 18 months minimum in their program. Next slide. Shortlister. Shortlister is a fabulous platform to help you find vendors to vet them out. So it's an RFP process. Many of you may be accessing these through your consultant. We are more than happy to run this for you, and we do it at a greatly reduced price. So 137 employers use Shortlister to research vendors and run their RFPs. 10 of those have been MBGH members. They have 3,500 vendors available in the Shortlister platform, 22 million lives out to RFP through Shortlister in 2020. It's very impressive. Our members who have used them have been very pleased with their results. Greater confidence level when they contracted with the finalist. And Judy Hearn has seen the employers all the way through the process, and she sits in on finalist meetings and really works closely with the employers in their decision process. And so we hope to see more of you access this. Next slide, please. So a health strategy is a part of the employer RX evolution that you've been hearing referenced throughout today. And you saw a presentation from Amy Ball today. She's their chief pharmacy officer at Health Strategy. So they have $50 billion of pharmacy spend currently under management there. The 40 self-funded employer groups with 10 national regional health plans. Greater than 30 clients are supported with customized formulary management. They have 15 pharmacy benefit management RFP procurement processes conducted. They resulted in new direct non-coalition contracts. So we had, reference to some of the consulting houses having coalition contracts. And we've had some of our own members move from those contracts direct to the PBM, contracting direct with that PBM. And that cost avoidance savings has been anywhere from 8 to 20%. And I'll share a little bit more on that. I have a case study actually to share with you in a moment. They launched the RX Marketplace this year. So they have made it even easier for the mid-size employer in particular to go to RFP and get a response rather quickly, in less than a month. They have gone out to PBMs, so there's 13 PBMs that have been selected. They gave them the criteria upfront that they needed to agree to in contract terms, and have really narrowed the field for who's willing to come to the table and meet those terms. And by doing that upfront, again, it really speeds up the RFP process because there's already some very specific agreements in place. So 6 clients are supported with specialty PBM carve-out arrangement, and Amy presented on that when she did the PBM carve-out along with the specialty on the medical side. And then 10 PBM market checks have been completed, 5 PM contract renewals negotiated, and captured, the contract value captured ranged from 3 to 8% of total drug spent in that. Next slide, please. So Rx results. Dwight Davis referenced them a couple of times today. They are also part of our Rx Evolution product or solution for employers. And they are spun out of the evidence-based prescription program that is directed by Dwight Davis at the University of Arkansas College of Pharmacy. So they provide formulary Rx guidance. And in this, you can see year over year results. So they have year 1, year 2, they've seen a 46% decrease in plan paid, 66% decrease in average plan paid per script, a 10% increase in generic utilization. So Darren had referenced just about every employer now is at a 90% utilization of generics. Well, there's still some employers who aren't there, and there's opportunity for them to create savings by moving that needle. And then a 49% decrease in member paid per script. So they are getting awesome results in this area, and we're really happy to have them as one of our preferred partners. Next slide. They also offer specialty Rx guidance. So they have an independent P&T committee to set the clinical criteria and run independent prior authorization for you on all of your specialty drugs. They had $1.7 million in prior authorization savings, 99 prior authorization results for specialty medications over a 24-month period. So in year 1, as you can see here, $778,000 in savings, and in year 2, just shy of $929,000 of savings. So this could be you folks. This is, we've got great opportunities here. If you're an employer looking to create savings, we have Health Strategy putting the right contract in place. They're also able to help you with formulary. And then we have Rx results with some other risk management formulary solutions that you can put in place with them. Next slide. We're really pleased to announce this that we're moving forward with, which is a rebate solution. So I'm going to contradict Darren from earlier, where we are able to go direct to manufacturer, and you don't have to have drugs in your formulary that you don't want in there. This is an opportunity for us to build on what Dwight Davis, again, has already started at the College of Pharmacy through the evidence-based prescription program. So we are fleshing this out, and in fact, working with Health Strategy to identify PBMs in advance who will participate with this program. But Rx results also, they have total solution to put in place, and we're very, very excited about this. So this is an opportunity, again, to go direct to manufacturer on the drugs that are getting to your member at the right time for the right place for all the right reasons, right? They're meeting all the clinical criteria. This is not about kind of filling things with drugs that you don't want in your formulary. This is about setting the formulary and then talking to the manufacturers about rebates for those drugs. So if you'd like to learn more about this, let me know. Happy to talk. We'll be ready to fully launch in 2022. So not too far off, another 6 months. Again, happy to have those discussions now. Next slide, please. So this is the case study that I referenced earlier. So this is a member of ours that has 8,815 total employees. They were in a coalition contract and still not 100% satisfied with the prices they were getting, not confident, and felt that it was in their best interest to go out to RFP and see what other opportunities were out there. They had tried many different plan design strategies. You see here a copay with predictable costs to steer towards generics, co-insurance with lower minimums and maximums to steer to preferred brand name, no separate deductible, mandatory maintenance, they changed PBMs, they had a more restrictive formulary, eliminated the outlier drugs, and there was still opportunities. So next slide. So this is what, after going out to RFP and choosing to go direct, and actually they had carved out their PBM, and that PBM got carved back in. So the PBM they chose is with their health plan, their carrier. And their anticipated savings over 3 years was $7.855 million. They had they do have total transparency. So they discovered a consulting fee buried in the PBM fees from their coalition contract. So they don't have that anymore. They have their current fee, administrative fee, is 2/3 less than what they had with their predecessor. 100% of identifiable rebates are coming back. And they received $5.3 million in 2020 versus they said 24% or $4 million in 2019. So 4% more in rebates that they're receiving. They have increased flexibility so they can pull more levers. With that, in 2021, this year, they have gone ahead and made some additional changes. They've removed the outlier drugs and adopted Performance Select drug formulary. They have minimal disruption, $636,000 in annual savings. Their net PM increases that they were seeing from 2017 to 2019 have now dropped. So in 2020, they saw a 7.4% decrease in their PM. So they went from, in 2019, having $108.18 per member per month to 2020, $108.18 per member per month. And they anticipate an additional drop this year with the formulary select that they've added. Next slide, please. So here, restricted formularies, $223 additional savings, right? With that restriction. They're reviewing the results for PBM supplied restricted formulary with their independent RX consultant and further restrictive formulary. They're looking to discover that prescription is not as economical or efficacious as low-cost alternatives. They'll proactively review drugs in the pipeline to gain an understanding of possible impact on their pharmacy plan. They look to direct contract with a pharmacy, and that was just not viable for them right now. But they are supplying their own specialty drugs. So I think this is an excellent example of the flexibility that they've gained through their contract negotiation, and that can happen for any one of you out there. You do not have to be an employer with 10, 20,000 lives in order to do this. Next slide, please. I think this brings us to the end. Yes, it does. And I'm not sure if there might be a question here. There was a question, there was a comment for Judy. and I'll just read this. So I wonder if employers are asking for similar price structures for other diabetes medications for type 2 diabetes, orals, GLP-1s, that also have cardiac renal benefits that insulin doesn't have. I worry type 2 diabetes patients will be moved to insulin due to cost and end up with poor clinical outcomes. So that's a really great point. I don't know, Judy, if you are aware of any employers who are making these others more accessible to avoid perhaps an unnecessary move, right, to insulin.
Well, and while we're waiting for her to unmute, I'll just mention that I don't know if those medications, which are all orals, I believe, correct?
Yes.
Are as much as insulin or significantly less, but it is a good point. I would, since it's an anonymous attendee, we really can't reply back to you, but feel free to reach out to Denise, Judy, or myself, and we'll try and answer that later.
Thank you. And so, Cheryl, I will turn this over to you for closing comments.
Great. Well, thank you all so much. What a great day. What a busy day. Lots of information. I'm sure your brains are full. Mindy is reminding us to complete the program evaluation, and she has included the link in there, and I ask that staff also, I think we usually mail it out to you, or excuse me, email it out to you, along with a link to the PowerPoints, and oftentimes we already have the webinar recording, so we'll send that to you as well. I want to thank our attendees. You guys were great. Thank you so much for being part of today. Again, we want to hear your feedback. I want to thank our sponsors for committing to us, and we hope the program is beneficial to all of you. Our speakers today were excellent, and we thank them. And don't forget about our upcoming programs, our purchasing model programs and services. You can reach out to Denise, and we look forward to seeing you again soon. Thank you so much, and all of you have a wonderful, wonderful evening.